or is making its way to the upper altitudes there. Good afternoon, everyone. I'm delighted to welcome all of our viewers to the Virginia Tech Carolina School of Medicine Research Symposium for the class of 2022. And we have some special guests to welcome as well. These are students that have been offered positions in our medical school in the class of 2026 who are here enjoying a second look. And so some of them will be observing our symposium today. We welcome you too. So this year marks a big step forward in our return to fully in-person symposium. It was refreshing to see so many people. I happen to be over in building 4 for this first poster session. So many people over there really enjoying being together again and looking at the wonderful work that our students have done. And here we are in the auditorium looking a little different than we did a couple of years back. Research is not just one of our 4 curricular domains. It's one of the defining strengths of the medical school as we pursue this mission of creating future thought leaders in medicine. The research domain contributes in a major way to the success of our graduates as they pursue positions in residency programs that not only value the research itself, but also how it prepares our graduates to apply the rigors of scientific thought into clinical practice. This is the VTC difference that distinguishes our graduates from students from other schools when they start in residencies and helps them stay up to date on new actionable research findings throughout the practice. Sometimes our graduates will be the first to responsibly implement new practices to improve care years before the consensus guidelines come out from organizations. Congratulations are in order to the class of 2022 for fulfilling the rigorous requirements of our research domain. I'd like also to extend my heartfelt gratitude to the dream team of faculty mentors for all of their support and encouragement of our students this year. Please join me in a round of applause for our mentors. It is now my pleasure to introduce a man who needs no introduction, Dr. Mike Friedlander, a man of many hats at Virginia Tech and the Fralin Biomedical Research Institute. He's here today also as our Senior Dean for Research in the VTC School of Medicine. I greatly appreciate his leadership and the leadership provided by our Assistant Dean, Dr. Leslie LeConte, in assuring the exceptional research experiences that you have all enjoyed. So welcome to Research Symposium.
So a man of many hats, but also pins. I have on the sesquicentennial pin. I can never say that word, but Dean Lehrman has many more pins and symbols of the 150th anniversary than I do, I assure you. Anyway, it is indeed a pleasure to be here and to welcome all the students, their mentors, and the special guests taking the second look as well. Once again, the research output and productivity of the students here has been spectacular and off the charts. And we are all deeply impressed and grateful for your contributions to advancing knowledge, which is such an important part of healthcare to move to the future. Dr. Lehrman has already mentioned the mentors and given them a round of applause. And I just want to second that by saying this just wouldn't happen without all the mentors. The faculty are willing to contribute their time with the students. And we are deeply appreciative of all the effort they put in as well. And along those lines, it is my great pleasure today to highlight one of those mentors who's embedded somewhere in that picture up there, Dr. Sami Lemui, who has been selected as the Outstanding Mentor this year to receive the Outstanding Mentor Award. I just want to make clear to everybody how this comes about. We solicit nominations from a lot of folks all around here, students that are here, students that have graduated. Many people can weigh in on this, and we have criteria for this. And that includes providing an environment in which original hypothesis-driven research is effectively implemented and guided. Secondly, providing opportunities for professional growth for the students. Thirdly, challenging mentees to make original contributions and making sure their projects are completed with rigor. Fourthly, fostering an intellectual growth environment and technical proficiency. And finally, establishing clear expectations and maintaining high standards. So it is to these points that alumni and current students have weighed in, and it's their selection. And we have been very honored and fortunate to be able to identify Dr. Sami Lemui to receive the award this year. By way of background, Dr. Lemui did his education, both undergraduate and PhD work in Grenoble, where he studied molecular biology. He then went on to San Francisco, to the University of California, San Francisco, to do postdoctoral training. And from there, he joined in the biotech industry and has worked in that industry for several years. And we had the great fortune of being able to attract and recruit him here several years ago when he joined the Fralin Biomedical Research Institute as an assistant professor, and also has a faculty appointment in the medical school and basic science education. Dr. Limui has won a lot of awards. One of them I'll note is an American Heart Association Scientist Development Award. And then he also has received what's called an STTR award for starting a company that takes his fundamental work on understanding how to develop new treatments for cancer, particularly directed at cancer stem cells as well. And he also was recognized by the land-grant institutions across the United States for very successful productivity in that area. He's mentored a number of medical students, I think at least 7 at this point, and the experiences have been uniformly outstanding. We get that feedback regularly. One of his previous students, Jean Sabile, won a letter of distinction for his research, and he has now gone on and graduated, class of 20. And he has one of the students in this year's graduating class, Natalia Sutherland, who's right there, who also has been selected to speak this afternoon, and you will hear from Natalia a little bit later. I want to mention one thing before I get to some comments from the students. There's an old joke in academia about people that get involved in the academic enterprise and also want to translate and commercialize their discoveries to the outside world. And it said they have one foot on the dock and one foot on the boat. And what generally happens when you do that is this. Dr. Limui is not of that. He is keeping both the boat and the dock moving in parallel in such a way that his contributions and his research are making a difference in terms of the academic rigor and standards, and also moving things out to the world to help people. And I think I know, because I've seen it, he really brings that to the entire operation. The students are around him see that. They're working obviously in an academic setting, but they see that he's able to embrace, and how important it is for him to embrace the concept of helping patients and helping people, and not just keeping discoveries in the lab. Sammy embodies that spirit, and I wish we'd see that in a lot more folks. So we're very proud of him in that regard. He inspires his students, and he includes them in this important vision. But don't just take my word for this. Let's see what the medical students had to say about Sammy. Firstly, one said, he's always enthusiastic, inspiring his students. Another said, his first instinct always stems from a place of equality. Another said, his expectations are always made clear and always in an understandable way. Another said, Dr. Limui's been instrumental in my medical school career. He's been incredibly supportive and a wonderful mentor who is really excited about my research. Another said, I genuinely believe that honing my curiosity in the lab has helped me think critically about how I care for my patients. And finally, one more said, Dr. Limui's mentorship has been an inspiration to me. So I think that says it all. It captures the spirit of exactly what we're looking for these awards. And really is a great honor and privilege to be able to recognize Dr. Limui today. And Sammy, if you wouldn't mind stepping up, we'd like to present you with the award at this time. So now we're going to have an opportunity to hear from Dr. Limui about his working with medical students over the years and his program. Sammy, all yours.
Well, thank you so much. Thank you for the nomination. I'm extremely honored to receive this award today. I've been very happy to be part of the Virginia Tech Carilion School of Medicine family for a few years now. So thank you again. All right, let me see if that works. All right, cool. So when I joined the Fralin Biomedical Research Institute, I think the first specific introduction to the School of Medicine was through the collaboration with Jennifer Vaughan in cancer research, our cancer research efforts. And many of you know Jennifer Vaughan. She's not here anymore. She joined the Ohio State University, and also through my collaboration with Leslie Laconte in me teaching a class on commercialization for first-year students. And so I think together, Leslie and Jennifer really have been instrumental in identifying students that they felt would thrive in the wet research environment, and thankfully send a few of them my way. So my first student, Jean Saville, was part of class of 2020. Now Jean is a second-year internal medicine resident at Oregon Health and Sciences University. Natalia Sutherland, Ario Soraya, class of 2022. They matched last week. Congratulations. And I want to extend my congratulations to the whole class of 2022. 100% match. That is amazing. Well done. Congratulations. Really, really well done. We're excited for you all. Natalia is joining residency in internal medicine at Mass General Hospital in Boston, while Ario is going to join residency in family medicine at John Muir Walnut Creek in California. Then came Chukwuemeka Wokeneme, class of 2023. Kenny Young. So Kenny started his research as a med student in my lab, co-mentoring with Jamie Smith. And then he jumped into the MD PhD program. We're really excited about that. So still in our lab, he joined the TBMH program. Then Danny Purcell, class of 2024. And finally, the latest addition to the team, Christine Marlowe, class of 2025. All right, so a little bit about the research in my lab. So we study tumor plasticity, and in the field, when you talk about tumor plasticity, one thing comes in mind, the epithelial mesenchymal transition, or EMT, but there is more to that. Tumor plasticity can enhance the dissemination of tumor cells to form metastasis, can regulate cancer stem cells, also generate drug-tolerant persistent cells, and also can induce dormancy in cancer cells. All right, and all those are connected. EMT can, of course, increase metastasis, generate cancer stem cell, and those disseminated tumor cells, cancer stem cell, can also become dormant and get reactivated at some point. And that's really critical, because this tumor plasticity, all these events, really makes tumors highly dynamic and highly heterogeneous. And that's a big problem when it comes to treatments. It brings a lot of challenges, because tumor plasticity is responsible for increase in tumor resistance, tumor recurrence, and tumor metastasis. And so each of the medical students in my lab has or is contributing to answering important research questions in each of these areas, as you can see here, by dissecting molecular mechanisms that regulate tumor plasticity, or studying the interaction regulation of tumor plasticity versus tumor microenvironment and vice versa. Also developing new technique to visualize tumor plasticity in vitro and in vivo. And finally, with the goal to find novel targets and therapies to target tumor plasticity. And they do so in the context of brain cancer, breast cancer, and colon cancer. All right, so as I mentioned, medical students contribute greatly to every aspect of the research in my lab, but it is extremely rewarding as a mentor to see when this experience can impact them directly with specific recognitions and awards, strengthening their CVs and their competitiveness, but not just for the next step, but for their entire career. And so here are some of the accomplishments for the students in my lab. Jean Saville received in 2018 a medical student initiation grant from the American Society of Colon and Rectal Surgeons. 1 year later, he presented at this conference in Cleveland, talking about targeting colon cancer stem cell survival with a novel connexin 43 mimetic peptide. And in 2018, he actually also had a poster presentation at the Cancer Stem Cell Conference in Cleveland, Ohio. Cleveland again, so that was unfortunate for two conferences to be. I don't have anything against Cleveland, but it's just, yeah, I mean, you know, they like to maybe see other city when they go in conferences. What Jean was really instrumental was to initiate an IRB protocol in collaboration with Jennifer Vaughan, Doug Ryder, and Farrell Atkins at Carilion. 2021. And so he was able to start the first biobank here at the Friend Research Institute biobank of colon cancer tissue. So, this has been extremely like instrumental for the research in my lab. All right, so Natalia received, her abstract was selected in 2021 by the American Society of Clinical Oncology. It was like a virtual meeting, but her abstract has been published in the very prestigious Journal of Clinical Oncology. And so make sure that you stick during the afternoon. Natalia is going to speak later today toward the end, and she's going to tell you more about her project on BMP4, connexin 43, and beta-catenin in glioblastoma stem cells. Ario has a poster presentation coming up at the American Association for Cancer Research. That's going to be next month. It's a hybrid meeting, but Ario is going to go there in person, so that's really exciting. And he's going to talk about connexin 43 macrotubule in EMT. Ario has also a poster here, so make sure that you stop by and check it out. And as I mentioned, Kenny, with a dual program, MD, PhD, Kenny received in 2021 $75,000 award from the NIH Diversity Supplement Grants. We are really exciting to have this support for Kenny and for his research in my lab and the lab of Jamie Smith. All right, so next, I really want to highlight how strongly I feel about having a diverse set of minds in my research team. So at lab meetings, journal clubs, we have, of course, med students, grad students, undergrad students, research assistants, and all together contributing to the conversation as we hash out our findings and plan next steps. So specifically, I want to say that medical students bring critical context, not just those from classes on physiology, etc., being fresher in their minds than my own. But also their reflections on their clinical experiences and how what we are doing may impact patients. All right, so as a mentor, this is rewarding to see the journey of a student that come to your lab, and I'm sure it's the same for all the mentors and the School of Medicine. So here, this is Jean starting in 2016, the white coat ceremony in 2018 with then Dean Johnson, and then Research Day in 2020, probably the worst year to have Research Day. As you can see, no audience for Jean. I know, but Zoom, people who are on Zoom. But that's how he graduated, and then now you can see him recently starting ICU, getting his first dose of vaccine there at OHSU in the middle of the pandemic. And then you see this, and this is actually, yeah, this is really an amazing thing to see from your students, and you hope that the research experience that he or she would get in your lab would just like carry on and follow them like in their career, and that they might use that when they treat patients, might use this knowledge. All right, so there is research, but there is, of course, life and fun, hopefully. I mean, this is, of course, like really important for to keep sanity. So unfortunately, not many events together, but hopefully we're gonna get back to more like socializing with the lab. The lab has been really fun. We have like a new addition here to the lab, Keris, who was born December 26, and Ario, and Natalia, and Chukwemeka, who might also consider maybe a different medical career with animals, because they have like a good touch. I don't think this is the same cat here, but they look pretty similar. I don't know. I need to ask Chukwemeka. All right. So of course, it takes a lot of people to enable the research components at the School of Medicine to work. But I just wanted to highlight those individuals whose support and leadership has directly impacted my ability to mentor these students over the years. So thank you, Dean Lerman, Mike Philander, David Music, René Leclerc. Thank you, Leslie, Alison. It has been so much fun to collaborate with you, and I'm looking forward to collaborate more, of course. Thank you to the support of Lauren Harris. She left a few years ago. Crystal Barnett, Jessica Flowers. You make things so much easy for us mentor when it comes to evaluating students or checking those progress reports. And Jessica, I need to apologize. I owe you a signature for Natalia's latest reports. And yeah, I'm gonna sign it this afternoon. Sorry about that. Thank you for your patience. And the IT team, of course, when our student presents, also a very smooth process. And today, research day, and the communication team for those wonderful article and pictures to highlight the accomplishment of our students. All right, so as our medical students head out across the nation to embark on their clinical research career, it is my hope as a research scientist and entrepreneur that their experience in the lab would stay with them and give them a different perspective and understanding of the bench to bedside process as they treat patients. So one of my favorite quotes from Marcel Proust, a French novelist and writer, who say: "Le véritable voyage de découverte ne consiste pas à chercher de nouveaux paysages, mais à avoir de nouveaux yeux. The real voyage of discovery consists not in seeking new landscapes, but in having new eyes." And so what I hope with the research component at the School of Medicine, I hope that this is your new eyes, that you're going to see things different with this research background when you move on to your career. As a scientist, if you ask me about having new eyes, of course, this is what comes in mind, but keep doing research always. Congratulations, class of 2022. I'm looking forward to seeing your research for the result of your research the past 4 years during this afternoon. Thank you again so much for the award. Thank you.
All right. So now we're going to get to hear from class of 2022 letter of distinction in research scholarship winners. So before we bring up our first presenter, I want to remind those who are viewing on YouTube that we are hoping to incorporate some of your questions. So feel free to put in the chat if you've got questions. And then those of you who are in the audience, we're gonna have about 5 minutes for questions at the end. So there are a couple of microphone stands. So jump on up and be nice, but ask some questions of your fellow classmate presenters. So letters of distinction in research scholarship are chosen based on a whole string of qualities. So based on overall quality, significance, relevance, innovation, and then clarity of the students' findings as they're communicated by the students either in their written form or in their oral presentations. So we have all of the evaluators and mentors weigh in on students' research and are looking not necessarily for something that's gone all the way through the publication, but something that is the quality of that study represents what we want to see from all of our student research studies. So the first presenter that we're going to hear from is Juan Choi. Juan worked with Dr. James Thomas. The title of her project is, you can read here, but use of intraoperative ketorolac in outpatient breast surgery. And she actually put together a double-blinded prospective randomized controlled trial. So Juan, if you want to come on up and we'll hear from you.
Okay. Hi, everyone. My name is Juan. My study was looking at the use of intraoperative ketorolac in outpatient breast surgery, and it was a double-blinded RCT. So I'll talk a little bit about my research question, a little bit about the background, about what existing literature is already out there, what my hypothesis was, how we want to go address those questions. The study is still ongoing, so I can share some interim results with you and some conclusions based on those results. So our overarching global research question is looking at how the field of plastic surgery can address the opioid crisis and reduce opioid usage in breast surgery patients. And so while we've made significant strides in addressing the opioid crisis nationally, you can see this data from the CDC from 2018 to 2019 actually found that there's still a 15% increase in drug overdose death rates involving synthetic opioids in the state of Virginia. So clearly we still have some work to do. And then my overarching clinical research question is whether or not ketorolac is safe to use in breast surgeries. And I'll talk a little bit about the existing literature out there that gives some plastic surgeons pause before using this medication. So looking at opioid usage in plastic surgery, so this study looked at almost 500,000 patients undergoing 5 different types of plastic surgery procedures, including nasal, eye, breast, abdomen, soft tissue reconstruction surgeries. And what they looked at was opioid usage in 3 time periods: in the perioperative period, the persistent period, which they defined as 3 to 6 months, and the prolonged period, which they defined as 6 to 12 months. And what they found was that breast surgery patients actually had the highest percentage of opioid usage amongst all the different types of plastic surgery procedures. They also did a multivariable logistic regression model, and they also consistently found that the breast surgery patients were most strongly correlated with persistent and prolonged opioid usage. So clearly within the field of plastic surgery, our breast surgery patients are kind of at the greatest risk of higher exposure to opioids. So one of the ways that surgeons will try to mitigate post-op opioid usage is just better intraoperative pain control. So a really popular medication amongst the general surgeons and different types of surgeons is this medication called ketorolac, which is also known as Toradol. It is a non-steroidal anti-inflammatory drug. It acts on our handy dandy arachidonic acid pathway, which we have seen 1,000 times in our medical school career. And it acts by blocking this COX-1, COX-2 enzyme here, and then preventing all of these downstream pro-inflammatory effects. So the idea is that if we administer Toradol in the operating room while the patient is undergoing surgery, hopefully when they wake up, they'll wake up in a little bit less pain. And then that will then subsequently translate to less opioid usage when they're recovering at home. One of the other additional questions that we wanted to ask in my study is, what is that minimum effective dose? Is there a lower dose that might potentially have all the same benefits of having the Toradol without going so high as a 30 milligram dose? So there's a question of what that minimum effective dose is. So all of that sounds really great. So why don't plastic surgeons use Toradol more often? It has to do with one of the effects that we block downstream here in this pathway. Thromboxane A2 is involved in platelet aggregation and hemostasis. So there is a theoretical risk by blocking all these downstream effects that patients who receive Toradol will have increased risk of bleeding and then develop hematomas, which is a collection of blood under the tissue and cause tissue damage, and can be a site of source of infection. So the data that currently exists out there looking at Toradol specifically in breast procedure patients is mixed. And so we've seen some studies. This first study is from 2012. It was about 400 patients, and they found that there was nearly a 4-time increased risk of hematoma formation in patients who received Toradol. A little bit more recent study from 2018 looking at nearly 800 patients found that when they compared patients who received Toradol with no Toradol, there's no statistically significant difference. So clearly there's conflicting research out there. And what I saw in the operating room would be when patients were undergoing breast procedures, the anesthesiologist would ask the attending, the surgeon, and say, would you like to administer Toradol? And the surgeon would kind of stand there, look at the patients, assess how oozy they were, and make this very subjective, sure. So that's kind of where I got the idea for this project, trying to look at more objectively whether or not Toradol was safe, and is this concern for hematoma formation valid. Notably, but all the studies that have been published so far looking at Toradol use in breast procedure patients have all been retrospective. So we know that retrospective studies are inherently tied with a little bit of bias. And so my study would be the very first prospective study looking at this question. So my hypothesis was that the intraoperative use of Toradol in breast reduction and reconstruction procedures would reduce postoperative pain and subsequently postoperative opioid usage, both in the immediate PACU period as well as post-discharge when the patients went home. And all of this would occur without increasing hematoma formation. We also wanted to address the question of whether or not a 15 milligram dose would be sufficient. So we hypothesized that there would be no difference in postoperative pain, postoperative opioid usage, and hematoma rate between the 15 milligram and the 30 milligram group. For our methods, we powered our study to have a target N of 183 patients. So that would be 61 patients per group. We did an ANOVA test and post-hoc analysis looking at pain control, opioid usage, both in the PACU period and when they went home, as well as hematoma formation. And we included patients, all patients 18 to 64 years old undergoing breast reconstruction or breast reduction procedures, excluding any patients who are pregnant, had a drug allergy, or essentially any contraindication for Toradol or opioids. This was a double-blinded prospective randomized controlled trial. And so we first identified patients in clinic when they would arrive in clinic for their first consultation visit. We would introduce the study to them. 1 week before their surgery, I would give them a call, kind of reintroduce the study, go over any questions they may have, and obtain the preliminary consent. I would then notify pharmacy, and they would prepare the appropriate study drug based on which group that they were randomized to. And then the anesthesiologist would administer the drug intraoperatively at the time of closing at the end of the case. And then before discharge, one of the plastic surgery residents would assess the patient for hematoma formation before they left the hospital. And every single patient who went home was sent home on a standardized pain regimen of 20 pills of Norco. Patients were then sent home with this patient diary, and we asked them to keep track of their pain scores on a scale of 1 to 10. We asked them to keep track of how many of those Norco narcotic pain pills that they actually end up needing to take while they're at home, as well as any over-the-counter medication that they had to take, which they were encouraged to supplement for their pain control. We also asked them to keep track of any sort of complications or side effects associated with opioid usage. Patients then returned this form at their first follow-up appointment in clinic. I entered all the data into REDCap and ran some data analysis, which I can share a little bit with you now. So the study is ongoing. And so currently we have 63 patients included in this interim analysis. I have about 140 patients enrolled in the study, but those latter half we're still waiting to get the patient diaries back from. So we've got a pretty good even distribution of patients in each group, both in age, ethnicity, and procedure type. And this graph, what we can see is it's showing the average pain scores and opioid usage by group. So on the left side here, we have the average pain scores on an 11-point Likert scale, as indicated by the blue bar graphs and the black numbers up top. And on the right, we have average opioid usage shown in morphine milligram equivalents on the right, shown by the red line and the white numbers on the bottom. And what you can see is that our 30 milligram Toradol group, that higher dose, had the lowest average pain scores of all the groups, and they had the lowest average opioid usage amongst all the groups. And then interestingly, the placebo group, which did not receive any Toradol and just got a saline injection, had the highest overall pain scores and the highest opioid usage. We looked at these outcomes a little bit more in depth. So what this is showing is post-op day on the x-axis and average pain scores on the y-axis. So essentially what you're seeing here is the rate of pain resolution over time. As time went on, pain went down. And what we found was that our 30 milligram Toradol group had the fastest rate of pain resolution, which was statistically significant when we ran our ANOVA tests. Interestingly, when we compared our lower Toradol group, our 15 milligram with the placebo, it was not statistically significant, suggesting that maybe that lower Toradol dosage is not enough to actually get the benefits of the pain resolution. We did kind of the same analysis for opioid usage. So again, this rate is showing the rate of opioid discontinuance over time. And what we found was that the 15 milligram Toradol group actually had the fastest rate of opioid discontinuance, but it was pretty close to the 30 milligram group. So the difference is pretty marginal. And these results were not statistically significant at this time, but as we continue to enroll more patients, we expect this to start to trend towards significance. We also looked at opioid usage specifically in the immediate PACU period as calculated by MMEs, and this also was not statistically significant at this time. And then the more clinically relevant question of hematoma formation. So far of the 63 patients who are enrolled and included in this analysis, we've had 0 hematoma formation. We did have one patient who was enrolled in the study develop a hematoma, but she didn't complete the study protocol, so she was not included in the analysis. However, even if we were to include her, the rate would be 1.5%, which is lower than the expected rate that you would see in all breast reconstruction and reduction procedures. So some conclusions based on these results that I've been able to see so far. That 30 milligram Toradol group is clearly doing great. They had the lowest average pain score, the lowest average opioid usage, the fastest pain resolution, and second fastest reduction in opioid usage, but again, by a very, very small margin. And then interestingly, we have no statistically significant difference between that 15 milligram and that placebo group. We've also looked at the PACU opioid usage, which is not statistically significant at this time. And 0% hematoma rate formation is that real key clinical outcome that I think will really help plastic surgeons overcome that barrier to entry of using Toradol in breast surgeries. A couple of limitations to the study. Obviously, pain is a very subjective experience. Patients have different pain tolerances, experience pain differently, manage pain differently, but that's a bias that kind of exists for any single study that looks at pain. I'd say the biggest concrete limitation to my study is that not all pain medications administered by the anesthesiologist intraoperatively and in the PACU period were not controlled for. So different anesthesiologists are going to have different opioid stewardship prescribing patterns. But our justification for that was it would be feasibly very difficult to control for every single anesthesiologist for every single procedure. And we decided that that variability of anesthesiologists' tendencies and preferences would be evenly distributed across all 3 groups. Patients were also encouraged to use over-the-counter medication, and some patients are more likely to use that or more likely to lean on the narcotics that we send them home with. So that was also a variability within our groups. And then obviously the COVID-19 pandemic halted our study for a little bit, so we're a little behind on enrollment. But for our future analysis, I'm excited to say that I matched here for plastic surgery, so I'm gonna get to continue the study as a plastics resident in residency. I'd like to acknowledge my mentor and now my program director, Dr. James Thompson, Joy Rodriguez, who was integral in helping me with the study, one of the plastics residents, the entire plastic surgery department, Jordan Darden, of course, and John Paul Rader, who are clinical research coordinators in surgery. And none of this would be possible without Dr. LaConte and Dr. Tibby. Thank you. Try to run away before the questions.
That's right. Any questions, please come. Is this on? Yes. Come forward, jump to the mics, and I'm looking at the YouTube chat if you've got questions for Juan. Dr. Friedlander.
Thank you.
My only question was, with the standard doses of 15 and 30 megs, I'm sure you have the data on patients' weights. Could you separate out in terms of milligrams per kilogram and see any differences when you looked at specifically the body mass and concentration effect?
It's a good question. We haven't done that, and it's something that we could do. The way that we came across decided on the 15 to 30 milligram was just talking to anesthesiology and seeing what their standard of practice was. And they told us we typically just use the 30 milligram dose regardless of the patient weight. And so I'm not sure if they dose it, pre-op, if they plan to use it. But I think the dose that they kind of have on hand is that 30 milligram dosage. So that's kind of how we came to that. Mm-hmm.
Other questions? Great. Yeah. I think the mics are on.
Okay. Hello, can you hear me? Okay. Super awesome, by the way. I'm going to bend down a little bit. Did you record concomitant medications? And if so, do you think there could be an interaction between NSAIDs, like over-counter NSAIDs that the patients could be taking post-operatively and the intraoperative NSAIDs they received?
Yeah, absolutely. One of the main exclusion criteria is renal function or any other contraindication for NSAIDs. So if there were patients who couldn't take a lot of NSAIDs or any, they weren't included in the study. So in that sense, for the safety of the patient, we controlled for that. In terms of the variability of what the patients were taking outside, I think that's the biggest limitation to the study is we couldn't control for everything, particularly because we're looking at the post-op period where they're at home. All we could really do is equally encourage all the patients to supplement with over-the-counter and with the Norco that we set them home with, and just assume that that variability is evenly distributed across all three groups.
Awesome, thank you, and congrats on matching.
Thanks.
Great. So I think we're gonna move on to our next one. Sorry, Caroline. All right. Yeah, I know our question period is pretty brief, but we've got a lot of great research to hear about. And we're going to shift gears a little bit now. We're going to move on to Dinesh Lal, who worked with Dr. Shannon Ferris at Fralin Biomedical Research Institute. And so we're going to get the chance to see some of his beautiful images of neurons and dendrites. So Dinesh, if you want to go ahead and come up, and we'll get you set up to go ahead and give your presentation. Do you want the mic or the lapel? Yes.
Hey everyone, my name is Dinesh. So here's a picture of a neuron, right? So there's two things I want to point out. So that's how the cell body is. And the rest of these things are dendrites. So these dendrites are important. Inside these dendrites, how do they communicate with each other? Well, the answer in physiology is usually like protein, right? So these guys, protein. The idea that I want to keep at the back of your mind is that neurons need proteins in their different. So that's like the main idea that nothing else. So the next question becomes, how does a protein get to where it gets? How does a protein get to where it needs? So this is what we learned in like cell biology. This Golgi apparatus proteins with sugar tags, and these sugar tags tell the proteins to where they need to be and help these proteins get to their final destinations. And that works beautifully for these super basic cells, right? If you imagine a cell, that's probably what you're thinking about. But the problem is neurons are not basic. They're like the prettiest cells. They're super exotic looking. And so there's the cell body. And again, those are the dendrites. And if you can imagine, it doesn't make sense for the stuff to be, or it doesn't seem efficient for all the stuff to be in the cell body when the proteins need to get all this way down through this dendritic arbor. And so the way that neurons have kind of evolved to work around this is this process called local protein translation, to where we know that in these neurons, there's endoplasmic reticulum, right? There's the ER to Golgi intermediate complex. But really the question that's been debated in the field for like the last, I don't know, 20 years is whether there's a Golgi apparatus there or not in these dendrites. And that's really like the launching point for my research. And so how are these membrane proteins processed to get to their dendritic membranes? And so the question now becomes, is the Golgi in dendrites, right? And so I've highlighted these two labs that kind of show two different trains of thoughts. So this first lab, there's a lot of words here, but basically they showed that there was evidence for Golgi in these dendrites. And their evidence was a little suspicious, but that's the tier they went with, is that the Golgi is present there. This next lab highlights another train of thought where they say that the Golgi is not present in these dendrites, but instead there's another process that's tagging these proteins to get to where they need to be. And
their evidence was also suspicious in its own way. They did their stuff in vitro, but they showed strong evidence for this one protein in immature neurons. And so really the long story short is that two trains of thoughts, right? Either it's yes, that there are Golgi present, or no, there are no Golgi present. And plenty of labs have been going back and forth about this. Research has been coming out for, again, the last 20 years, and no one's been able to agree on anything, which obviously is why they brought me in. And so the clinical correlation or a clinical correlation here is through autism. And again, neurons need proteins in their dendrites to do their jobs. And autism is one of the issues in autism is that these dendrites are not communicating with each other as well as we'd like them to. So moving into my actual research is that question and what I was doing. Long story short, I was basically a bounty hunter for the last 4 years looking for the Golgi apparatus. Super exciting. So my research question specifically was is the Golgi apparatus present throughout hippocampal dendrites in vivo? And there's no middle ground in science, so I had to pick a side. And my hypothesis was that the Golgi apparatus is present throughout hippocampal dendrites, and we'll go from there. So I just want to highlight these 3 antibodies we selected because I'm going to be talking a lot about them in the next few slides. But GOGA5 is the antibody that stains for the Golgi apparatus. ERGIC is the antibody that stains for the ER to Golgi intermediate compartment. And then SC3-Gal stains for Golgi outposts, which are like this somewhat newly discovered organelle. And we'll talk a little bit more about them towards the end, but they have some Golgi-like properties. So how did I do this experiment / what were my methods? So these are the antibodies we were going to stain with, right? But the first step was getting over my fear of mice and handling them, then sacrificing these mice and treating them, getting their brains out, getting their hippocampi out, sectioning the brains, then finally staining these brain sections, trying to figure out what was going wrong and why my staining was not working as well as I would have liked it to. Finally getting to the microscope room, learning Fiji and analyzing with Fiji, and then putting everything together in a hopefully aesthetically pleasing way in this presentation using Prism. So jumping into my results, first thing I'm going to talk about is GOGA5, which is the canonical Golgi. And what we found is that it's present in our cell bodies, but not distal dendrites. And to highlight here, so these are the cell bodies. And to highlight here, this is the layer that we're currently looking at in the hippocampus. So these are cell bodies, and these are the dendrites. So in green, anytime you guys see green in this presentation, it's labeling the entire neuron, and then all the other colors are going to be the antibodies we're looking at. So if I take away the green channel here, and in this case, GOAD is GOGA5. So if I take away the green channel here, you can see that there's still plenty of signal left over, right? Indicating that this antibody is present in these cell bodies, especially when compared to this negative control over there. Moving into the dendrites, which again is this layer right here, you can see that there isn't much gold on this picture, right? In fact, there's none. And so if I take away the green layer, there's nothing left over. There's some noise, but that's the same as the negative control there. And so again, this is indicating it's in the visually at least that this protein is that the Golgi is present in these cell bodies, but not the dendrites. And then to kind of show you guys this in a more analytical way, I'm going to walk through how we did this. Each one of these circles here is an individual cell body. And on the end here, fluorescence intensity, these numbers don't really matter all that much. It's whether it's there or not, right? We're interested in seeing, can we figure out whether we're seeing signal or not and put that in a graphical way. And so since it's not 0, you guys can see that there is signal there, and that's reflecting what we saw visually in terms of there being signal in these cell bodies. So GOGA5 is expressed in cell bodies. With dendrites, it's a little bit trickier, but we developed a way to figure this out. And so if we zoom in this box here, that's what that is. And then what we did was we transected these 2 dendrites. And where we transected them, that line essentially measured the signal along that line. And so these arrows correspond with these arrows up here. And you see 2 peaks in the GFP here because that indicates there's signal from the GFP, meaning, yeah, you're in a dendrite because the GFP is labeling the dendrite. But there's no corresponding peak in gold, indicating that that gold antibody, the GOGA5, is not inside of that dendrite. If it was, you would see a corresponding peak in gold. And I'll show you some examples later of what that would look like. So GOGA5 is not expressed in our dendrites. And then this is just comparing the cell bodies to the dendrites. It's easier if we look at a ratio. And so if the ratio was 1 here, it would indicate that, that this antibody is dispersed throughout both the cell bodies and the dendrites. And if it's closer to 2, it would indicate that it's more in the dendrites than it is in the cell bodies. And if it's closer to 0, then it would indicate it's more in the cell bodies than it is the dendrites. And so as you can see in this, like for this antibody for Golgi 5, the ratio is closer to 0, indicating, yeah, this is definitely present in our cell bodies, but not so much the dendrites. And that's what that says. Okay, so the next antibody, again, was ergic, which looks at the ER to Golgi intermediate compartment. And looking at our cell body layer, if I take away the green, you can see there's plenty of signal there, right? You still see magenta. So ergic is present in these cell bodies, at least visually. And now it's a little bit different when we move over to the dendrites. If I take away the green layer there, there's still plenty of magenta. So this antibody is dispersed throughout these dendrites. And so if we do that graphically, again, we're in the cell bodies here, and each one of these is a cell body. You can see that there's fluorescent intensity present. So ergic is expressed in our cell bodies. So the ER to Golgi intermediate compartment is expressed in our cell bodies. And now going into our dendrites, which is like what we're most interested in, same kind of thing. If we look at the measurements along this line, you can see that where there's a peak in GFP, there's a corresponding peak in the ergic channel, in the magenta channel. So that means because these peaks are corresponding, that where there's a dendrite, this antibody is also present in that dendrite. And so ergic is expressed in our dendrites. And then again, if we're just comparing the cell bodies to dendrites, if I show you guys the ratio, it's close to 1. So this means that this antibody and the ER to Golgi intermediate compartment is pretty uniformly expressed throughout the neuron in general. And then last but not least, our Golgi outposts. So using SC3 we were able to stain for those. And so if I take away the green layer here, you can see that there's still plenty of magenta, indicating that that it's present in these cell bodies. And then if I move into the dendritic layer, if I take away the green there, it's still super bright purple. And so this antibody is also present in our distal dendrites. And then graphing that out this way, so SC3 is in cyan here, and essentially there's signal present. So it's showing us that, yeah, SC3 is expressed in our cell bodies. And then same thing with the dendrite graph here, where you see a peak in the GFP, you also see a peak in the cyan. So this antibody is present, and this protein, the Golgi outposts, are present in our dendrites. And then looking at the ratio, if I show you guys this, again, close to 1, so pretty uniformly present throughout the entire neuron. All right, so the next natural step of my experiment was to go ahead and see if I can get higher resolution images to see, like, how clear can I see these proteins? Sorry about that. So all the images I showed y'all before were in 40x, and these, so we redid everything and looked at it in 63x. And so this is using ergic, and now you can see individual ergic particles using the 63x microscopy. So it's easiest to see, I think, in this image, because the green is labeling the neuron again, and you can see these little like white dots, and those white dots are actually like individual ergic compartments. And you can see, like, you can start telling the nature of like what they actually look like and what their physical properties are. And then if we do that in the dendrite, same kind of deal. If you look at this image here, where the white is, you can see these individual compartments located inside of these dendrites. Or moving into SC3 same kind of deal. You can see individual SC3 particles visible using 63x. So in the cell body, yep, you can see these little white dots. And so now you can see that these are like more punctate. And then if we use the dendrites, same kind of deal. You can see throughout this dendrite that you can see these tiny little dots. And each one of those dots is an individual Golgi outpost that's present in that dendrite. And then as I was doing this, I realized, well, now we have a high enough resolution where we can see dendritic spines, right? And so dendritic spines are like these tiny little like bumps at the end of the dendrites, but they're important for cell-to-cell communication. And so the question became, are our proteins that we're staining for localizing specifically to these spines? And so I'm no expert in Fiji, so it took me a while to do this, but I figured out a way to kind of measure the intensity inside of these spines. And this is like the newest part of my experiment. And so these are like the freshest results we've got. And so we'll talk about those quickly. And so essentially, visually at least, it looked like these proteins are localizing to spines. And so if you look here, there's a spine, right? And this is using SC3 Gao. And inside of that spine, you can see like that little powdery, like white area. And you can see that throughout a lot of these spines. And so visually, it seemed to me at least like ST3-gal is localizing to our dendritic spines. Same kind of deal here with ergic. This is done slightly differently. It's using like a heat map. But you can see if I zoom into these yellow circles where the spines are, the intensity is like darker red, meaning, or at least implying that the intensity of these proteins is stronger in these areas compared to the rest of the dendrites. And so I went ahead and graphed these, and I literally did these like a couple of weeks ago, so it's like brand new stuff. But what we're seeing so far is that ST3-gal and ergic, at least when I put it graphically, are expressed evenly in the dendrites and the dendritic spines. But again, since this is so new, like there are definitely ways that I, or hopefully another medical student, can go back in and like revamp this part of the experiment to get stronger results. All right, summary interpretation. What did we learn? So the canonical Golgi, right, the Golgi apparatus, as we know, is confined to cell bodies. The ER to Golgi complex is found both in cell bodies and dendrites. And then Golgi outposts are found in cell bodies and dendrites, right? So these last 2 points are important because it shows evidence that we can stain for these small encapsulated organelles in these distal dendrites, meaning if the canonical Golgi was there in dendrites, we should have been able to see it because we saw these other organelles. And there are definitely different kinds of microscopy we can use to continue following up on this. And then here's an image, like a more higher resolution image, staining for Golgi-5, which again stains for the canonical Golgi. And you can see in this image that really all of the staining is stuck in that cell body layer and not so much this dendrite layer. And there's a little bit of noise there, and the way these things are done, it's like in layers. So there are some like rogue cell bodies that are present here, but really you'd be able to see inside the individual dendrite if that antibody was present there. And my conclusion, so we talked about these first 2 points, right? It's just showing where these antibodies are located. Again, Golgi-5, if you look at this graph, it's closer to 0, so it's more so on the cell bodies and dendrites, and the other 2 are more uniformly expressed. But this last point is important. So we did not find evidence for the canonical Golgi apparatus protein markers in distal dendrites, suggesting that a non-canonical trafficking pathway utilizing specifically Golgi outposts likely processes transmembrane proteins in distal dendrites. So that was a mouthful. What does that actually mean? So there's a lot of research that's being done right now. Like the people that actually study this are all kind of somewhat coming to a conclusion that the Golgi outposts are like what's important in terms of tagging these proteins to get to where they need to be in these dendritic membranes. And really, this is super interesting because it's kind of reflecting like what this research showed, right? Those Golgi outposts are definitely present in those dendrites, and other labs are kind of looking into like what the function is and what they're doing there. And we're thinking that they're doing the job of the Golgi apparatus. Future directions, we can repeat this experiment using autism mice. We can further explore the roles of ergic and ST3-gal. We can repeat with other Golgi proteins, and we can do more colocalization studies. So I need to thank some people real quick. First of all, the people in my lab, especially Logan and Katie, for showing me where the antibodies are roughly 5 million times and for always being there to help me out. Dr. Ferris for always being there to help me and help guide and push me through this project. Dr. LeConte for always making me feel like someone had my back. And then obviously my wonderful medical school class for sitting through one of my presentations.
Nice job. If somebody's got a question, feel free to jump to a mic, or I can hand one to you. I'll let Natalia first and then Dr. Smith.
Hey, Dinesh, great job. I'm surprised to see like none of our like faces from Facebook on that presentation, but I'm glad, you know. I was just wondering, what was your promoter for your GFP neurons?
Ooh, that was so long ago. Honestly, I do not remember what the promoter
Okay,
was.
no, it's fine.
I'm not gonna pretend.
Damn, I was
Sorry.
lowballing it for you, man. And also, how would you explain some of the background that you saw in some of your immunofluorescence images? Like, I believe that you have colocalization in some of your images, but I was just wondering, like, there was still a significant amount of background, and how would you explain that, and how would you mitigate that in the future?
So that one I can answer. Sometimes the staining in the background can be things like astrocytes, so those stain. Other times it could be because these images are like stacked on top of each other. You might get like a neuron or a dendrite that's in a slightly different plane. And when you overlap everything together, it's staining that thing that's out of focus essentially. But yeah.
All right. Did I share?
Okay.
Hey, for the first time in my life, I got to be nicer than Natalia. This is great. So I saw you present this a couple of years ago on Zoom, and I have to say there's a lot more of you in person. That was a good presentation. So what do these Golgi outposts look like by EM? And are they being made on site, or are they like being made and transported? Are they all active? I was surprised that they were distributed so evenly.
Yeah, so that's a great question. So like the way that we're seeing them is that they're less like vesicular in nature than the ergic, than the ER to Golgi intermediate compartment, and they're more like punctate in nature. So they're more like defined. In terms of whether they're being like transported, it seems like they're just so evenly distributed that like I would think that I guess they're just present in all these areas. I'm not sure if they're being transported or not. I guess that's something I can look into and the rest of the lab can look into.
Great. Is this on now? Yes. Okay. Thanks so much, Dinesh. Excellent job. All right. Our last presenter of this session, we're gonna change pace again. We're going back to the clinic, and we're gonna hear from Corey Cablet, who worked with his mentor John Tuttle in orthopedics. We're gonna see some different positioning in terms of starting procedures, according to Dr. Nussbaum, not surgeries. Is that right? So Corey, we're gonna go ahead and hear.
Stoking the pot with the surgery versus ortho. I like that. Let's clip this to my belt. Can you guys hear me okay? I want to make sure this is on. I got a thumbs up. Thank you. Thank you to my roommate who always helps me out, Keenan. Thank you so much. This can go inside the belt loop here. All right. So first of all, welcome to all the prospective students. I don't know if you guys are in this room. I'm really happy you guys are here. I remember being in your shoes. I just want to welcome you guys specifically. So welcome to VTC. Again, my name is Corey Cablet. My mentor is Dr. John Tuttle. We did a prospective clinical trial comparing general anesthesia with an interscaling nerve block versus TIVA-P sedation, also with an interscaling nerve block and outpatient shoulder arthroscopies. A little bit of background here. Shoulder arthroscopy, it can be used to repair various types of pathology in the shoulder. So rotator cuff repair, labral repair, bone spur removal, and many others like an impingement syndrome, et cetera, et cetera. Carilion has about 420 of these done every year, both in the inpatient setting and also the outpatient setting at the RASC. That means the Roanoke Ambulatory Surgical Center. Here's an image here that you can see that's a little bit of a background of what they do in these procedures. You have some small incisions that you have that put some scopes and instruments in that allow you to take care of the pathology and fix whatever you need to fix inside the joint. In regards to surgical positioning, like Dr. LeConte mentioned, there's two positions that orthopedic surgeons typically use. One's called the lateral decubitus, which you can see here. The patient lies on their side. The arm is kind of ratcheted up, and then you can gain access to that joint and perform your procedure. The other position they do is this beach chair position. So beach chair position because you sit like you're sitting in a beach chair. And as you can see, the patient stays upright in this position here, and then the arm again is ratcheted up, and then they can do the procedure. Some surgeons prefer this method because it gives more advantageous angle of attack, and so they can do a little more manipulation of the joint. Currently at Carilion Clinic, when we do these procedures, the anesthetic method we use is an interscaling nerve block with 0.5% bupivacaine. So they go into the brachial plexus, and then they'll inject some of this bupivacaine, and that will cover the deltoid as well as the posterior side of the arm for up to 12 hours after the procedure. In addition, they use general anesthesia, which is with an inhaled anesthetic, either be sevoflurane or desflurane. Some of the side effects of general anesthesia, I think most people have heard of some of these. The most common ones are going to be your post-operative nausea and vomiting, as well as your short-term cognitive impairment. This is associated with some prolonged hospital and PACU, that stands for post-anesthesia care unit stays. And then also they have this chance of cerebral desaturation events, fancy CDE. But pretty much what happens here is you have this momentary instance of hypoperfusion in the brain. And we'll get into why this happens in a sec. But this precedes nausea and vomiting, and also to combat this, anesthesiologists will typically give perioperative interventions like vasopressors. So they look at the mean arterial pressure and make sure it's okay. So going through some of the actual physiology of this, we have a little diagram here. So we have a patient sitting in the beach chair position, right, upright. They got their interscaling block as well as general anesthesia. And when they're sitting up, gravity is going to take control and the blood will pool in the feet. We have a decreased sympathetic response because we cannot vasoconstrict because our general anesthetics are very vasodilatory. And so we're going to continue to pull at the legs, which means we're going to have a lower total peripheral vascular resistance. which means we have a lower mean arterial pressure. And then we can have these moments of hyperperfusion and desaturation in the brain. And just thinking about the areas of the brain that control nausea and vomiting, if you're not providing blood, you're probably going to feel a little sick afterwards. And that's when that's connections there to your postoperative nausea, vomiting, and short-term cognitive impairment that results from that. Now, tangibly, this can lead to increased hospital and post-anesthesia care unit times and stays, an increased risk of having an inpatient admission after your operation for any of the issues here, as well as we can have increased use of our perioperative interventions. I mentioned vasopressors are used by the anesthesiologists. And of note, which is quite interesting, currently they measure your blood pressure on your brachial cuff. So you're sitting upright, so your brachial cuff is going to be lower than your head. And so that actually overestimates your mean arterial blood pressure from about 15 to 20 milligrams per mercury. And so you can be getting an accurate reading of blood pressure on your brachial cuff monitor, but you'll actually not be perfusing the brain. So in order to combat this, the different approach for anesthesia would be total intravenous anesthesia or propofol. And what happens here is the patient gets the same bolus of propofol to induce anesthesia, but instead of being intubated and put on an inhaled anesthetic, we're going to have a continuous propofol infusion. This has been shown to decrease the risk of the cerebral desaturation events, and it can lower your postoperative nausea, vomiting, and cognitive impairment. And all my wonderfully intelligent medical students can make this connection already, so why this could be happening. We'll go to that in a slide. Interestingly, though, one thing I want to note is that in a previous study, about 27, more than half of the patients who got a nerve block and also sedation bypassed the recovery room. That'll be important here in a sec. This was done in maxillofacial surgeries, not shoulder surgeries. So let's go over this one more time with sedation. With beach share, again, there we have venous pooling, but we're sedated now with Tiva-P. We can actually maintain our sympathetic response. And I know some of our classmates here can be like, well, propofol is vasodilatory. It is, but we're infusing at a rate of 80 to 200 micrograms per kilogram per minute. And based upon that infusion rate, we can still squeeze down the extremities. And so because of that, we can have a normal mean arterial pressure and normal perfusion saturation, and then ideally less postoperative nausea, vomiting, and short-term cognitive impairment. And then for the patient, we can have our decreased hospital and post-anesthesia care unit times and stays, decreased risk of admission, decreased risk of antiemetic use, and also decreased risk of perioperative interventions to maintain our mean arterial pressure. So this was the idea that our group and Dr. Tuttle wanted to look at. Is how can we improve the experience for patients in the outpatient setting by using Tiva and hopefully get them to be discharged earlier with less side effects? One of the ways we can look at that is actually look at the structure and the flow of what happens in an outpatient surgical setting. So we can kind of break up into three different blocks. We have our preoperative care unit, we have our surgical suite, and we have our post-anesthesia care unit. Patients are going to arrive, they're going to go to their pre-op unit, they're going to get their physical by Dr. Tuttle, and then the anesthesiologist will come by if that's cleared, and they'll do their interscaling nerve block and ultrasound and get them with some 0.5 bupivacaine. Once that's settled, they go to the surgical suite where they'll be induced with anesthesia. Again, that's always with a bolus or propofol, and depending on what arm they're going to be in, they can either get propofol in an IV or intubated with general anesthesia. They're going to get their surgical procedure, and then the surgery will go great, and then afterwards they'll go to their post-anesthesia care unit or PACU, where they have a post-op evaluation by the anesthesiologist. And here is where they're going to make a determination where they push them to what we call the post-anesthesia care unit phase 1, which then goes to phase 2, or they can expedite the patient to go right to phase 2. And I'll go over what this means and what we use to dictate where the patient's going. And then afterwards, they're going to be discharged. So looking specifically at this post-anesthesia care unit block here, what are the influencing factors for our phases? It's going to be 5 things: physical activity, respiratory status, consciousness, nausea, vomiting, and pain. And so phase 1 and phase 2 are different levels of nursing requirements on how often you need to check on the patient, but we're going off of these 5 factors to push them along to get them discharged. And so if a patient's skipping phase 1, they are more physically active, have a better respiratory status, they're more conscious, they have less nausea and vomiting, and less pain. And so interestingly enough, I bolded this and then italicized those because I've already talked about this with Tiva. Tiva tends to help with their postoperative nausea, vomiting, as well as our cognitive impairment. So if we can improve those things, we can expedite the patients through this process and get them discharged earlier. Going back, when we look at our study, we're going to look at our endpoints. And what we decided to do is choose a primary endpoint for our study of the phase 1 to phase 2 transition time. We wanted to see how many of these patients are skipping that first phase. And some of our secondary endpoints are going to be the time the patient met their actual discharge criteria, and then also how many perioperative interventions were used and how many antiemetics were used. And I want to highlight this is in the perioperative setting. So this is not in the PACU. This is how many interventions were given in the surgery, and also antiemetics were given in the surgery. Other endpoints would be satisfaction from both the participant and the physicians, surgeon and anesthesiologist, pain both pre-op and post-op. That's with a modified PROMIS pain score, and surgical time as well. And so the way our study flow worked, again, we had 1 surgeon, 3 anesthesiologists, and we had a total of 192 participants that are going to be in the study. This is broken into 4 blocks. We currently have 1 block completed at 48 patients, and we're in process for the second block right now. Then we have 2 other blocks to do if we can meet these things called interim analyses. Again, each block is broken up into 24 participants per arm. I want to bring in this thing called interim analyses and what this is. And so with our study, we're going to break it out into 4 blocks because we want to make sure we can follow our primary endpoint and make sure that once we meet that, the study is then completed. There's no reason to ethically continue our study unless we know, while we know that our primary endpoint's been met. So after all these blocks with an interim analysis with a different p-value, they start off really small. Our first p-value was 10 to the -6, which is very small. And they continue to get larger after that. So with this first block we completed, again, we did it with a p-value of 10 to the -6, looking for our endpoints. This is our demographics for that first block. I know there's a lot here, but I'm just going to draw your attention here to the p-value sign. There's nothing here that was significant statistically between our 2 groups. You can see our ages, the gender distribution, the weights, the heights, and the body mass index were all similar. And we looked at certain comorbidities, so diabetes, hypertension, alcohol use, smoking, and also the mean systolic and diastolic blood pressures, and those were all similar between the groups. So continuing with our data, here's our primary endpoint here, the time to our phase 1 to phase 2 transition. You can see that the group that got our intravenous anesthesia here on the left, they had approximately 10 minutes of this day, which is pretty much the physical, and then moved on to phase 2. As you can see in my note there, 21 out of 24 patients skipped PACU1 like we were expecting, compared to only 2 out of 24 in the general anesthesia arm. So you can look at the number there for how much time they spent. They spent about 25 minutes if you got general anesthesia in phase 1. Again, that's the p-value, 0.0052. It was not significant for our study, but I think that's important to note. I think that's a good trend. And then for our time to be discharged criteria, which is one of our secondary endpoints, we can also see that people, our participants who got our IV anesthesia were discharged a little bit earlier. So we have about 45 minutes for those who got TIVA and about 56 minutes for those who got general anesthesia. For those of you who are looking at my error bars, they're quite wide. They are quite wide. So let's dive into why they are wide. So if you actually replot this data on a box and whisker plot, I think we can see this a little better. So looking at our primary endpoint again at that transition time, here's what we see. We see some cases here where, and this is in the intravenous anesthesia group, that stayed quite long in phase 1. And so if we look at that and say, like, hey, what are the reasons, again, we went over this, that influence our stay? So those 5 things: physical activity, respiratory status, consciousness, nausea, vomiting, and pain. These 3 patients received fentanyl in phase 1 because they had a chronic pain before their procedure. And so receiving fentanyl is going to impact our respiratory status, our cognition, as well as our physical activity. And so what that effectively did was giving fentanyl for their pain prolonged their stay in phase 1. We didn't have any of this in the general anesthesia group from what we saw, but this was something that impacted our TIVA group. Looking at our time to be discharged criteria, we can see that there is still, there's a little bit of a skew here because of those patients that stayed a little bit longer. Again, if you stay longer in phase 1, you're going to stay a little bit longer until you're discharged. And we have a nice little distribution here for our general anesthesia group. Another interesting part of our data from block 1 is the other secondary endpoints of average antiemetic use, and then also perioperative intervention use. So I'm going to guide us through here, this data set here. We're going to start on the bottom here on the left. So what we're looking at is how many patients received no antiemetics, or you can also see in the parentheses how many did. The majority of patients of both arms received antiemetics. That was not something we were quite expecting with TIVA. We thought we would have less use. And kind of looking at this and diving a little bit further, what ended up happening, we just saw some specific patterns with our anesthesiologists. Some like to use antiemetics more often than others. So if the patient had any remote complaint of postoperative nausea vomiting before, they would give a antiemetic to prophylactically cover the patient. So we could be missing data here, because when the patient reaches the PACU, they're being given an antiemetic, they're not going to have nausea and vomiting. And when they are given an antiemetic, you see that each arm gets approximately 1. Moving on to the perioperative interventions, I mentioned this could be vasopressors, this can be albuterol, also oxygen. We were expecting this to be lower in our TIVA group, and it was actually quite similar. So again, most patients had some form of perioperative intervention. And diving into this a little bit further, what we saw was that this is quite closely tied to the comorbidities that patients had coming into their surgery. And actually, interestingly, those who have chronic hypertension have a paradoxical reaction to their induction to anesthesia. So those who tend to be hypertensive, when they're induced to propofol, their systolic blood pressures will drop immensely. And so we've seen systolic blood pressures drop from about 150 systolic down to about 80, and which requires the anesthesiologist to immediately give a vasopressor. That happens in both arms. So that was something I think that also contributed to this. Moving on to average surgery time, the surgery times are similar. It was no difference there. With pain scores, again, this was a modified pain score, very simple score. And there was no difference between the two arms there, pre and post-op. Satisfaction is something else we looked at. Our surgeon was very satisfied with both groups. Our anesthesiologists as well were satisfied. The reason why you see a little bit of variation is there are some cases where equipment was quite challenging for the anesthesiologist, but besides that, they were very pleased. And we saw that the patients were more satisfied with the intravenous anesthesia group compared to general. And so when you think about satisfaction, I think it's a conglomerate of both the medical treatment you received as well as the system itself and the people you interacted with. So we're going to keep an eye on this for the next couple of groups and see if this continues to play out. But currently we have higher satisfaction. So for our clinical conclusions for that first block, again, like I mentioned, we had a p-value of 10 to the -6. It was very small. We had no significant differences that we observed. But the trends are really encouraging. We saw that the patients who are getting intravenous anesthesia are skipping phase 1 PACU most of the time, and as well are being discharged a little bit earlier. And we will hopefully expect to see this become significant later down the road in different blocks. So let's talk about lastly, the impact and implications of what this study does. I think this is important to know. So some of the implications, this does influence patient care. Because currently right now we use general anesthesia at Carleen Clinic. We don't often use TIVA. And so this has the potential to change that. There's a couple different outcomes that we can do depending on how our study evolves, but this could be a viable and possibly even preferred anesthesia method for specifically outpatient shoulder surgeries that met our inclusion criteria. One example, we have the same outcomes as general anesthesia. That is, it's a non-inferior approach, which means it's a viable approach. Patients can ask for that if they would like. Or secondly, we may have better outcomes. And in that case, if we do have better outcomes, we should go back to the drawing board and say, is this actually a preferred method now to use in the outpatient setting? But until then, like I mentioned, we're on to block 2. That was our data from block 1. And we're hoping to see a difference here soon. Some of the acknowledgements I'd like to make would be Dr. Tuttle, who's our surgeon, Dr. Kazemi, Smith, and Joseph. They are wonderful anesthesiologists. Andrea Ewan Chavez is our clinical research coordinator. Jamie Gills is a PA. Anita Vanover has been great, as well as Dr. Teggy and Dr. LeConte.
Escape before questions. All right, any questions for Corey? All right, we got a question. Jane's gonna ask a question.
So 2 questions. So the first one is, you were talking about how with the anesthesia propofol, you saw people that were chronically hypertensive had a big drop in their blood pressure. I was curious, was that kind of controlled for the amount of propofol that was given to each patient and based on weight?
Great question. That was during the bolus. So I think patients are typically bolused. I think it's the same amount. I think it's, if I remember correctly, I think it's 100 milligrams to bolus them to get them deep. That was the point at which people were becoming hypotensive. So that was consistent.
So everybody was given the same dose,
Correct.
No matter if they weighed 300 versus.
Correct. Yeah, they overestimate to get them deeper immediately.
Oh, okay. Just I was thinking, maybe the you can see hypertension related to, obesity and other factors. So maybe that was a confounding factor. And then my other question was just like, how do you calculate your sample size?
Oh my gosh. So yeah, the sample size. So we start off with the sample size a little bit lower than that. But when we do your interim analysis, we have to make this correction called a Bonferroni correction. Every time you look at data, you have to add more data. And so, and what I'm saying is, so our sample size started off at about 96, and we just calculated that with 80% power with an alpha of 0.05. And then because we had to do interim analysis, that ballooned and grew.
Thank you. It was a great presentation, Corey.
Hi, thanks for the presentation.
Hey, you're welcome.
I was just wondering if you had any exclusion criteria.
Yeah, we do. So I originally had the exclusion criteria up. It took like half a slide. So I was like, well, but the exclusion criteria kind of, they exclude based upon whether you'd be excluded from general anesthesia, an interscaling nerve block, or you'd be excluded from TIVA. And so that there's a couple of things there. So say like you have a brachial plexus injury, you have any issues with your airway, things like that. Those are all excluded. And so there's a little long host there. I can explain them on my poster downstairs if you want to come see me afterwards.
And
No, not to be today.
just really quick, did you look at excluding those chronic pain patients, and did it make a difference?
So we did not. No, we didn't. And I think there was no data that looked at TIVA and chronic pain in outpatient surgeries from what I could see. And so we included them. I think that's a very good point, that if we were to continue and study this further, we'd want to try to like stratify that out a little bit.
Thank you.
You're welcome.
All right, one more round of applause for everybody who presented today in this session. So now it is time for the second poster session. Students, I want to remind you to get your votes in for all of our student poster awards. So use the QR codes and make your votes. And then join us back here, let's see, at 3:50. Thank you, everybody.
Emailing Adam.
I would suggest, I don't know if some other
viral infection. This work was done by Patrick Calhoun, who's since graduated from the Smith lab, and he's using Ad5, which is a human adenovirus. This is looking at connexin 43 expression at the protein level, because this is a Western blot, at 24, 48, and 72 hours. This is the control, and then the Ad5 infected. So if we quantify this, now we can quantify this. Now it's quantified. So we can look at the results, and we have at 24 and 48 and 72 hours, there's a significant reduction in connexin 43 at the protein level in the infected cells. We can do this a little more subjectively, but it looks nice. So these are control and infected cells. We're looking at the nuclei in blue, the big circles, and then a smattering, these little punctate things as the connexin 43 in green. The only difference here is these cells are infected, and we see that by the red is showing the E1A protein of connexin or of the virus of Ad5. And we see a subjective decrease in those little punctate green things. So at this point, Patrick also showed that even though while there is a decrease in connexin 43 at the protein level, there's also a decreased function of connexin 43. So that brought us to the next point where let's see what happens with multiple cells and how they relate to each other. This is calcium imaging, helping show like the discharge or the firing of these cells, thinking that they're all contracting together. So you can see in the uninfected cells, they all seem to beat together. They're all fluorescing at the same time. This is contrasted by the infected cells. I'll draw your attention to these boxes. Those cells seem to be doing their own thing. So if we quantify this, we can look at the peak fluorescence. Each line is its own cell. So we have 3 cells here, and all of those peaks, the peak fluorescence is all lining up together. So they're beating at or firing at the same time, kind of like beating at the same time if you think it's a myocardium. This is contrasted by the infected cells, and we see that these peaks are somewhat dysynchronous. So we can see that the pseudomyocardium isn't working very well together. So this brings us to our research question. How can a novel mouse model provide insight into cardiotropic adenovirus pathogenesis? So we're building on some prior work. First, we know that viral myocarditis can be arrhythmogenic in humans. We know that Coxsackie virus B3 downregulates connexin 43 expression in mice. As we've just discussed, we know that human adenoviral 5 significantly decreases connexin 43 expression and function in vitro in human cells. And finally, there's this newly described mouse adenovirus 3, which appears to be cardiotropic. There's some gaps that we're hoping to fill. So to this point in time, there hasn't been a satisfactory model or animal model for adenoviral myocarditis, in part due to the species specificity of these viruses. Also to this point, there hasn't been a lot of research in the earlier acute stages. Most of the research has focused later with the development of dilated cardiomyopathy. And finally, the arrhythmogenic mechanism and effect on gap junction during that acute infection hasn't been well studied. So this brings us to our hypothesis. We hypothesize that acute myocardial infection by MADV3 provides an arrhythmogenic substrate prior to substantial immune system infiltration of the myocardium. And we address this hypothesis with 2 main aims. So first, define the molecular changes to the heart during MADV3 infection. Second, investigate the effect of MADV3 infection on the intercalated disc and gap junction formation. So go over our broad experimental methodology. So we take mice and inject them retroorbitally or behind the eyeball with either the virus or sterile saline for the control. 7 days post-infection, we look at the electrical activity in the heart using an electrocardiogram or ECG. Then we sacrifice the mice. Some of them went with Dr. Sarah Barrett at VetMed for whole specimen histopathology. Some stayed with us, where we looked for the presence of the virus in the tissues, both at the nucleic acid level and the protein level. We also looked at host proteins in these tissues, so connexin 43 and other ion channels. And then we looked at the localization of these proteins with confocal microscopy. So I'll start by using this qPCR for viral DNA figure, and we can see that there is substantial enrichment of viral genomes in the heart compared to all other organ systems. So this was our first bit of evidence that supports the cardiotropism that had been previously suggested. Next, we looked at the tissue pathology. So in the top row, A, C, and E, these are uninfected animals. B, D, and E are infected animals. And in the brain, heart, and spleen at 7 days post-infection, there is no detectable inflammation or necrosis. Draw your attention to this lighter spot here in the spleen of an infected animal. That's follicular expansion, so it shows that there's an active immune response starting to mount. We also confirm this with a significant increase in spleen weight in the infected group, showing that the immune system is occurring in the spleen, or the immune reaction is occurring in the spleen. Next, we use adult ventricular cardiomyocytes to look at what happens when we infect them in vitro, and then what happens with some of the proteins. So first, we have the mock infection, and we see sodium channels in red, and then DAPI, the blue, is the nuclei, and then the green here in the infected ones is showing the viral presence. So at 24 hours post-infection, there's 100% infection of those cells. And even going 24 hours, they maintained a viable morphology, so they were still alive. Next, we looked at sodium and calcium channel localization. So draw your attention to this part of the figure, and the green is the sodium channels. And so we see they're localizing at the sarcolemma, or the surface of the muscle cells, where we'd expect them to be. And we see calcium in red at the T tubules, again, where we'd expect them to be. Other work also showed that sodium and calcium channel function was intact. So we have sodium and calcium channels localizing correctly and functioning well during acute infection. So next, we wanted to look at the main connexins in the heart. So that's connexin 43, connexin 40, and connexin 45. We found that in infected cells, the connexin 43 level, transcript level, was significantly decreased in the infected ones. There was no significant difference for connexin 40 at the transcript level in the infected cells, and there was a significant decrease of connexin 45 transcript in infected cells. And again, this was actually in myocardial tissue, not in cells. So that led us to think about the function of connexin 43. So other work showed that despite there was a reduction in connexin 43 transcript, there was actually normal protein level of connexin 43, but there was abnormal function. And so one way that we can have change in connexin 43 function is through phosphorylation. And so we were hypothesizing that with viral entry into the cell, it would increase phosphorylation of connexin 43 at serine 368, which would then decrease the open probability of these gap junctions, reducing ion flux, and then reducing conduction velocity, and also reducing the propagation of that innate antiviral response. And so that's exactly what we saw. We saw there's a significant increase in phosphorylation of connexin 43 at serine 368. So we also looked at the electrical activity in the heart with ECG. Under normal unstressed conditions, none of the infected or uninfected mice had any arrhythmias on ECG. So we ended up doing a sort of stress test by giving them epi or epinephrine and then seeing what happened with their ECGs. All of the uninfected mice maintained a normal ECG strip even with that epi challenge. However, one of the 6 infected mice started to develop a pretty significant premature ventricular contraction burden, or PVC burden. And although PVCs can be normal, as the burden increases, it starts to point to a pathology. Even more worrisome, upon epi challenge, we saw that there was complete AV dissociation. So the arrows indicate the P waves, complete disregard for the QRS complexes, so there's a complete block. This is confirmed by the substantial increase in the PR deviation in infected cells compared to infected mice compared to uninfected mice. And then finally, there is a significant increase in the RR interval in infected mice compared to uninfected mice, showing that there was a bradyarrhythmia arising. So I'll boil down some conclusions. We demonstrated that MADV3 is cardiotropic and can produce an active infection in the myocardium. Future work in this area, we could extend more than 7 days and see when and if the virus ends up producing cytotoxicity, and when and what type of immune infiltration happens in the myocardium at a later time point. As I mentioned, there's no clinically evident morbidity or mortality during those 7 days of infection. That's very similar to human cases of sudden cardiac death when people don't even know they're sick and then they can drop dead without any warning. If we, again, extend this model, we might be able to pick up some cases of mouse sudden cardiac death, or at least pick up some cases of cardiomyopathy. And it's important to mention that these electrical changes are happening before the development of any cardiomyopathy. So if we had put an echo on these mice, it would have looked normal, despite them having very severe electrical abnormalities. This begs the question of where in the myocardium is the virus infecting? So is it in the nodes? Is it the extended conduction system? Further work will look at trying to decipher this using node-specific antibodies. And finally, we've seen that connexin 43 is downregulated at the transcript level, normal in terms of the level for protein, but that protein is not functioning the way it should. And then Rachel Paget has separately shown that potassium currents are altered. So both of those phenotypes could be very worrisome for arrhythmias, but we're having them in the same mouse, and so this could be even more dangerous. So we've already done some optical mapping in conjunction with the Pulsing lab, but further work in that area can kind of elucidate that. So with that, I'd like to thank everyone in the lab, especially Dr. Jamie Smith, Rachel Paget, everyone else on this slide, and Dr. LeConte, Dr. Teggy. And I'm happy to answer any questions.
All right, any questions? We've got microphones on either side. Looks like we've got somebody coming down to ask a question. And for those of you who are watching in streaming rooms, feel free to join us in the main auditorium. Go ahead, Paul.
Great talk. Thanks so much for that. I know it was one of your future directions, but just wondering if you saw any infiltrate aggregation in the myocardium itself, because that's one of the characterization of myocarditis.
Right, that's a great question. So we didn't do any specific immune staining. We just did the H&E staining for histology. And just with the simple H&E stain, there wasn't anything on that kind of superficial look with histology. But it's a good point. In the future, we could do like specific immune cell lineage staining to see if they're there, in just a smaller quantity than we'd pick up visually with the H&E.
Nice. And sorry, just one more follow-up. In terms of looking at connexin 43, did you look at any other muscle markers like sarcomere actinin, just looking at the muscle itself and seeing if there's alterations in that cardiac muscle?
So we are more focused on the ion propagation because of the implication of the connexin 43. So we didn't look at the muscle function in terms of the muscle architecture itself.
Cool. Thanks so much.
Dr. Friedlander has a question.
Fantastic, thank you. So my question relates a little bit to her second question. I was thinking about cardiac performance in terms of, for example, left ventricular ejection fraction. And so I'm trying to recall from Rachel's work and your work, were you doing echocardiography on these animals?
So echo has been done in the past with Mira Tannenbaum, who graduated a few years ago. I can't at this time remember the specifics. I think she wasn't using mouse adenovirus type 3.
Okay.
Yeah, okay. Okay, so she actually did help us out for it, and it was normal? It was normal.
Okay. Okay. Well, that's really interesting. Again, relating back to that question, just the overall performance. I mean, arrhythmogenesis aside, in terms of when you get, good contraction, that things are working okay, basically, right? Okay, very interesting. Thanks.
All right, I'm not seeing any other questions, so let's thank Mike North again for a great talk. Yeah, thank you. All right, we're going to now hear from Keenan Michaels, who worked with Jeff Stein at Fralin Biomedical Research Institute. And you're going to hear some about delayed discounting, which I think some of you may be familiar with, in an interesting application. So Keenan, go ahead.
How about now? All right, great. That's my roommate. Thank you. All right.
Good afternoon, everyone. Thanks so much for coming to watch this. I'll be discussing smoking cessation following COPD diagnosis, and we'll be talking about how delay discounting looks in that setting. I'd like to thank my mentors, Jeff Stein and Jennifer Vaughn, who is now at The Ohio State University. Probably the most important thing in my PowerPoint is that "the" right there, but also Dr. Allison Teggy and Dr. Warren Bickel. So we'll jump right in and start talking about some smoking statistics. It may not be a surprise to many that cigarette smoking is the leading cause of preventable death and disease in the United States. You can see a quick map here of the United States and see that in our area, West Virginia area, you can see where Carillion gets its patients from is this most significant area of smoking in the country, as well as the Deep South. And there are almost 500,000 deaths every year attributable to cigarette smoking. This is actually 1 in 5 total deaths in the United States are attributable to cigarette smoking. So a very significant issue certainly that we face. In Southwest Virginia, as we zoom in on our state specifically, has the highest rates of smoking, up to 28%. And so a very significant level of smoking. The national average is more like 16%. So a very significant issue sort of specifically in our area. And so if you spent any time around VTC or FBRI, you've probably heard the term delay discounting, but we are, certainly many others are listening in today. So I'll kind of give you a quick rundown. Delay discounting is a measure for desire for immediate gratification. You can sort of use the time value of money and how you appreciate money in the future to determine your impulsivity. And so kind of the textbook definition is the degree to which one discounts or devalues a reward as a function of the amount of time until that reward is obtained. So again, just kind of valuing the future. This is described by K or ED50 in the literature. ED50 is a little bit easier to understand, I think. And it's the amount of time for the delayed reward to lose half of its value. This is sort of a classic discounting curve. You see 2 different patients here with different K values or different ED50 values. And so this patient, just a theoretical person here, would of course experience half of their discounted value, or their ED50 would be shorter than this individual whose ED50 would be more about here. So just kind of, we use these terms in delay discounting to measure the impulsivity. Each of us has an ED50. I could, everyone has devalues money over time, but those who are addicted to smoking, other things, it's well studied that those people have a shorter ED50 or delay discount more significantly. So how do we determine your delay discounting, this strange term? We ask you questions like, would you rather have $500 now or $1,000 in 4 days, maybe 3 weeks, maybe 3 years? And again, everyone has some indifference point where they would accept the $1,000 at that future time. And we can do this very quickly. Historically, this was like a 27 question questionnaire. But we can do this with 6 questions now, the 6 trial discounting task. This is actually established here at VTCRI or at FBRI by Dr. Kafarnas and Dr. Bickel. But we can do it very quickly, about 30 to 45 seconds. So that's important, very important clinically if this is going to be used in that setting. So delay discounting in smokers specifically, let's zoom in there. So it's very well established that smokers discount more than non-smokers. Here's never smokers and current smokers, well established in the literature that never smokers value the time, they delay discount less than smokers. And in a clinical sense as well, it's also very important to remember, and we'll bring this up later as well, but rates of discounting can be altered. So if you have some valuation of the future, if I can use what's called episodic future thinking, and this is actually kind of well studied by my PI, Dr. Stein here, it's called episodic future thinking. If I can make you think about the future more, imagine yourself in a certain amount of time, what are your goals, these sorts of things, we can actually alter your discounting. So that's certainly something that's very clinically important as well. So it's kind of worth mentioning my original project sort of pre-COVID. Our goal was to study this in head and neck cancer patients. We were recruiting at BRCC. This is kind of what I came into VTC started to do. And we did all these things to try and increase our recruitment. We were having a really hard time. So we expanded the inclusion criteria, whether they needed surgery or not surgery. We doubled the compensation. We added recruitment at the ENT clinic over at Riverside. But we still had a lot of trouble. There were a very low number of quitters, first off. Basically everyone that we recruited at that, by the time COVID rolled around, kept smoking. We had 1 quitter, I think. Patients were seeking treatment outside of Carillion, so we were sort of losing these patients that weren't coming back. There was a lack of desire to participate in research generally. And then of course, COVID-19 sort of shut down research for quite some time. And so it was our original plan. We were kind of foiled. So we ended up going in a different direction. And so instead of tobacco-associated cancers, why don't we look at COPD? Also something that a very significant proportion of the US population suffers from, certainly way more than head and neck cancer. It's still very intimately tied with tobacco use, right? The more tobacco you smoke, the more COPD you're gonna get. And it's very, if you stop smoking, it's very positively, the disease is very positively impacted by your stopping smoking. And finally, continuing smoking has very negative consequences for the disease course. So a very similar disease state, but certainly one that was going to be a little bit easier to recruit. And so of course, smoking is the most common cause of COPD. This probably comes as a surprise to no one here. And if you continue smoking, you'll experience worsened lung function, lower quality of life, less mobility and endurance, just a bad situation to be in. And in fact, 50% of all smokers, if they live long enough, will develop COPD, so a very significant percentage. And COPD alone accounts for 20% of that all smoking-related mortality. So again, it was going to be a little bit easier to recruit this population, and it's a very similar-looking population. So we pivoted to that direction. So we kind of put ourselves in the context of a smoker, and this smoker smokes, and they eventually down the road, they are diagnosed with COPD. So they can either go one of two routes after this patient here in the middle. They can either be patient one, who's a non-smoker after COPD diagnosis. They're diagnosed, they decide, oh my gosh, I'm going to stop smoking. They're able to quit. As addicted as they are, they're able to quit. Or they can go to patient two, who continues to smoke. And so the question we were sort of wanting to answer is, how can we identify this patient, patient two, before they continue smoking? If we find someone here, can we determine whether they're going to go to one or two? And so we hypothesized that potentially discounting would be one way that we could differentiate patient one from patient two. And so that kind of got us started. And so we knew that there was very little delay discounting study done in the field of COPD or other tobacco-related illness. I showed you the graph earlier. It's well known in smokers versus non-smokers, people who overeat versus don't, people who drink alcohol who don't. Well studied in that population, but not really in a disease state. So we wanted to see how that would potentially affect things. And so our overarching research question came, can we better understand smoking cessation following COPD diagnosis using delay discounting? Our subsequent hypothesis was smokers diagnosed with COPD within the last 5 years who show lower rates of delay discounting at the time of investigation will be more likely to have quit smoking since diagnosis. So here's our little timetable. We have a patient taking our survey at time 0. This is last summer that we were administering these surveys. We were using a Qualtrics-based recruitment as well. So we had a lot of trouble recruiting patients here. COVID had moved in. Let's recruit patients online more quickly. We can also get a way larger breadth of people from all over the country. So we used Qualtrics to recruit COPD patients. Qualtrics is kind of cool. They can sort of target, they have a lot of information on their panelists, and so they can sort of target different groups of people. So they were able to target people that they felt would probably have COPD, or at least a high likelihood. So we wanted patients diagnosed within the last 5 years, and then at some time point T, either stopped smoking or continued smoking. And so that's, again, sometimes in that last 5 years. So our inclusion criteria was 15 plus, living in the United States, having a current COPD diagnosis that they had received within the last 5 years, and they had to have reported daily or almost daily smoking at the time of diagnosis. And so there were we used some somewhat creative ways to sort of determine these things without asking them specifically in our screening criteria. And so we were looking for 320 quality completed subjects with our Qualtrics recruitment. Our survey, just to kind of give you a little bit of sense of what we were asking these people, had some demographic information. We used the 6 trial monetary discounting task, and then some smoking and current behavior questions. We asked have you used cigarettes in the prior 30 or 7 days? And we used that 7-day question to define a quitter, right? So if you've used not even a single cigarette in the last 7 days, we defined you as a quitter. We also used the Fagerstrom test for cigarette dependence, the FTCD, and that just is a test that I'll explain here shortly, but just kind of helps us understand how addicted and dependent on cigarettes you are. We asked that before and after COPD diagnosis. We asked people to think about how they would have felt then and now. And then we also used the CCQ, which is the clinical COPD questionnaire, which is a validated COPD self-assessment. They're actually kind of cool tests, so I actually kind of threw them up here real quick. But essentially, we asked, this is a small portion of the CCQ. We just kind of asked people to rate between never and almost all the time, kind of how short of breath they were feeling at rest, doing activity. Are you concerned about your breathing getting worse? These sorts of things to kind of help us get a sense of how bad someone's COPD was, so that we could maybe correlate that with their smoking or not. Then the FTCD is again the cigarette dependence test, and this is a quick 6-question test. The higher the number, the worse, the more addicted to cigarettes you are. This is kind of very well established in delay discounting literature and otherwise to determine kind of how addicted to cigarettes one is. So this kind of also helped us get a better context of the patients that we were asking and surveying. Here's our quick consort diagram. We surveyed or assessed 2,101 for eligibility. Again, this is sort of a targeted population. Qualtrics, they said we kind of get you people that we think will have COPD. So certainly this is not like it's not that 580 people have COPD out of 25% of the population of the US obviously does not have COPD, but this is a little bit of a targeted population. So a lot of people were screened out for various reasons. We had 545 complete the survey, and then 384 were included in data analysis after sort of data cleaning efforts were made. You can sort of see the reasons for that here. So we had 384, which again is above our 320, which we were hoping for. So that was great. So our results in our population, our clean data, we had 73% continue smoking after diagnosis at the time of investigation, time now, and then 27% had quit. This is actually very well models the sort of expected quit rate after COPD diagnosis in the literature. So quick demographics, we skewed a little bit towards female. Our age was about 45 average. We had a significant proportion of our population was white, and then 46.6% had a 2-year degree or more. And this is probably a little bit skewed as well. Usually doing an online type survey, you can usually skew towards generally more educated people. So we were sort of expecting to see this a little bit. Certainly a perfect study would have maybe had a broader range of educational experience. Our patients on average before diagnosis were smoking about 17 cigarettes per day. This is just less than 1 pack on average. And they had about 2.7 years since their diagnosis of COPD at the time that we were investigating them. So we did a univariate analysis to start. And so just looking at, all right, just COPD, just delay discounting, does that predict smoking cessation? So we did a logistic regression. You can see that the discounting curve is logarithmic. And so we did a logistic regression. And smoking cessation, again, was defined by that 7-day point prevalence abstinence. And we found that higher ED50, so better valuation of the future, a lower delay discounting, was indeed associated with a higher probability of smoking abstinence. There's the stats for Will. He always likes to see the stats. So that's for him. But it was significant. So we were excited to see that. That aligned well with our hypothesis. So then we looked at a multivariate analysis, kind of bringing lots of different variables in. A Bayesian information criterion modeling essentially just takes lots of different predictors together and tries to work out the best model from those, trying to limit certainly the amount of predictors in that model as well. So we found that increased age decreased COPD severity, which is defined by our CCQ questionnaire, and then decrease FTCD, again, that's our cigarette dependence questionnaire. These were the best predictors of smoking cessation since COPD diagnosis, again, with our 7-day point prevalence abstinence defining having been abstinent. So you can see delay discounting in here was not included, but the way we kind of looked at this data was there's definitely some interplay between DD and these things. It's well established that the more significantly someone is addicted to cigarettes, the more significantly they're going to discount. So there's probably definitely some interplay here between these predictors and delay discounting that's probably caused it to sort of be put out of the model. So again, that was not necessarily part of what we're looking for, but that was what the model selected. So in conclusion, we saw that delay discounting was indeed significantly different between the abstinent and non-abstinent groups when we were just looking at delay discounting, but the BIC model didn't select delay discounting as the best predictor of smoking cessation. And again, that's probably because of some interplay. So that's certainly a future direction we'd like to go in, is kind of work out how delay discounting varies with these other predictors. And the final future direction, and sort of way down the line, and something that this, we certainly hope to inform in the future, is kind of how can we target smoking cessation resources for those that have high delay discounting and so that we can more effectively help them quit. Again, kind of imagine some sort of scenario where a patient comes in, they are smoking, they just diagnosed with COPD. If we kind of have some sense of their impulsivity, we can do that very quickly, less than a minute. We can maybe help target them with specific smoking cessation resources, maybe more effectively than we could otherwise. So that's again, kind of the big picture of really what we're trying to get a better sense of. And again, maybe can we use episodic future thinking to help them quit as well? Lots of interplay here. I'd like to open up for questions. Thanks so much. We got to present at the Society for Research on Nicotine and Tobacco. So there's me. So thanks so much, guys.
All right, great talk. Questions for Keenan?
So I'm just wondering if you look specifically at smoking or at other tobacco products as well, like vaping or dipping.
Yeah, so we did actually collect some data on if someone had quit, did they kind of pivot to vaping or just chewable tobacco or chewable tobacco or chewable nicotine. We have not kind of analyzed that data yet, but we did collect that data. So that's certainly something we hope to do here very soon.
Yeah, I look forward to hearing about that.
Yeah, thanks so much.
Any other questions? Yep, Dr. Friedlander.
So beautiful study. And to follow on the question there, can we take it to the next step? I wonder about the delay discounting in the context of tobacco or nicotine only. So what about alcohol? What about medical compliance? Did you collect information on those sorts of things outside of the smoking domain?
Right, so my lab certainly does. This particular study was just sort of in the cigarette, literally a cigarette usage context, but certainly that is where a lot of the delay discounting research is sort of going, is to getting a better sense of, not only cigarettes or alcohol, but also like overeating or other addictive behaviors. Someone that uses their medications better than others. There's lots of study happening in breast cancer setting where are we using people that are adherent to their medications better or not? Is there delay discounting there? So that's certainly where a lot of different things are going. So we're excited to see that.
And if I can just follow up, the question I don't think you're going to have the answer, because I believe nobody does, but I'm curious what you think about it. It's the big question about delay discounting and these things. Do these individuals with these differences come to smoking with a set of parameters of delay discounting, or does somehow the utilization of the compounds like nicotine affect it? What do you think about
Yeah, that's a great question. So it's as you might imagine, a lot more difficult to do. There have been some small studies that do more of a prospective analysis, right? Kids who are 15, what's their delay discounting? Can we follow them over time? Did they pick up smoking or not? I think so there's been very little data there. I think my hypothesis lies more on they already delay discount significantly, and that sort of puts them at risk and having a propensity to start all of these things and then continuing that process, continuing to be addicted or whatever the behavior may be, further worsens that process and more significantly has their delay discounting be more high. Yes, sir.
All right. Thanks so much, Keenan.
Thank you.
Great
Appreciate
talk. All right, now we're going to hear from Natalia Sutherland. She worked with mentor Sami Lamoui, who we heard from earlier in the first session. She's going to share some of her signaling studies that she's been doing with beta-catenin, and I don't have your slides up yet. BMP, glioma stem cells. Looking forward to it.
All those. Yeah, I think so. Hi, everyone. My name is Natalia Sutherland, and for the past 3 years, I've been working with Sami Lamoui, looking at the role of connexin 43 and beta-catenin and their interaction in glioma stem cells. So glioblastoma is the most common and most malignant central nervous system tumor in adults, and it affects about 5 out of 100,000 patients per year. The treatment for glioblastoma involves surgery, radiation, and chemotherapy. However, despite these invasive therapies, most patients experience tumor recurrence. And the median survival for these patients is only 14.6 months, and the 2-year survival rate is only 26.5%. Again, most of these patients experience tumor recurrence, and we postulate that this tumor recurrence is due, at least in part, to the presence of glioma stem cells. Glioma stem cells are a subpopulation of cells that exist within the larger glioblastoma tumor that are resistant to chemotherapy and radiotherapy. So when these treatments are administered, these cells persist and then are able to undergo either self-renewal or a differentiation process by which they lead to tumor recurrence. So of course, there are several signaling pathways that are involved in the differentiation and maintenance of glioma stem cells, one of which that's involved in differentiation is bone morphogenic protein 4 or BMP4. So BMP4, when it binds to its receptor and phosphorylates SMAD1 and 5, they then associate with SMAD4, translocate to the nucleus, and then transcribe genes that are involved in glioma stem cell differentiation, decrease cellular proliferation, and increasing in cytoprotective pathways. This entire process is inhibited by the addition of noggin. Contrarily, Wnt beta-catenin, when Wnt binds to the frizzled receptor, the disheveled complex is released and sequesters the destruction complex at the membrane, which allows beta-catenin to translocate to the nucleus and transcribe genes that lead to glioma stem cell maintenance. Now, I've represented these two pathways in opposition, and there's a lot of literature that suggests that they do exist in opposition. However, there's also been evidence to show that they crosstalk in both tumor genicity and in neurodevelopment. And one of the ways that we think that these pathways are crosstalking is through connexin 43. Connexin 43 is a 43 kilodalton gap junction protein, 6 of which that may oligomerize to form a hemichannel, and 2 hemichannels may juxtapose to form a gap junction. Interestingly, connexin 43 has been shown to have both oncogenic and tumor suppressor roles. So this difference in connexin 43 is one of the reasons why we studied it. So you can see here connexin 43 functioning in its gap junction form, allowing the passage of small molecules and ions from one cell to another. However, the Lemley lab has discovered a non-junctional function of connexin 43 that is tumorigenic or tumor promoting. And that has been shown in, through connexin 43's interaction with microtubules. You can see here in glioma stem cells, connexin 43 is shown in cyan and beta tubulin in red. These are super res images. And you can see that in glioma stem cells, there is a lot of association between connexin 43 and microtubules. However, when we differentiate the glioma stem cells using fetal bovine serum, there's this huge increase in connexin 43 protein expression. And you can see just more connexin 43 in this super res image. While there's more connexin 43, there's a decrease in its association with microtubules shown here by this pair correlation, which leads us to wonder is if there is this increase in connexin 43 after FBS-induced differentiation, is there a similar increase after BMP-induced differentiation? And if so, what is the role of that? That brings us to our overarching research question, which is, does connexin 43 play a role in BMP-induced differentiation in glioma stem cells? And we hypothesize that BMP-dependent regulation of connexin 43 expression and localization modulates Wnt beta-catenin during glioma stem cell differentiation. We addressed these questions using 2 aims. And aim 1 is focused on the contribution of BMP and connexin 43 expression localization during glioma stem cell differentiation. And aim 2 is focused on connexin 43 and Wnt beta-catenin during glioma stem cell differentiation. So we looked at these aims using human-derived glioma stem cells. These cells were donated to us from the Sheng lab, and his lab has harvested these glioblastoma tumors, and we have enriched them for a subpopulation of glioma stem cells. So the first thing that we had to do with these glioma stem cells was make sure they were in fact sensitive to BMP. So we looked at, we treated our VTC037 cells with BMP4 and BMP7, and you can see here the activation of SMAD1 and 5 that's inhibited with the addition of noggin. And these results were again recapitulated in VTC001 glioma stem cells. So now that we understand our cells are sensitive to BMP, we wonder what is the effect of BMP on connexin 43 expression. And we treated our cells for 1, 3, or 7 days with BMP4 treatment, and we see that there is a significant increase in the connexin 43 protein levels shown here in the quantification of the above Western blot. We also looked at connexin 43 mRNA expression, and we see a similar increase after 1, 2, and 3 days of BMP4 treatment. These results were again recapitulated in VTC001 glioma stem cells. And so you can see here after 3 and after 7 days in BMP4 treatment, there is a significant increase of connexin 43 protein expression. And similarly, there is an increase of connexin 43 expression after 1 and 3 days of BMP4 treatment when we looked at mRNA. So now that we understand there is this increase of protein and mRNA of connexin 43, we wanted to better understand the transcriptional regulation of connexin 43. So when we look at a list of transcription factors for connexin 43, you see this list is long and by no means exhaustive, but we see beta-catenin is found on this list. And because of our aforementioned crosstalk in our signaling pathways, this did pique our interest. So this made us wonder, is the BMP-induced increase in connexin 43 mRNA dependent on beta-catenin transcriptional activity? So for beta-catenin to be transcriptionally active, it must first translocate to the nucleus. So we used an immunofluorescence assay to assess whether or not beta-catenin was translocating to the nucleus. And you can see here in these no treatment images, the nuclear stain is shown here in blue. In the no treatment cells, there's much less beta-catenin in the nucleus than in the BMP4 treated cells. And this result is quantified in this graph here. So yes, beta-catenin is translocating to the nucleus, but now we need to determine if it's transcriptionally active. So using a beta-catenin transcription inhibitor called LF3, we again treated our VTC001 and VTC037 glioma stem cells with BMP4 or BMP4 and LF3, and you can see that the significant increase in connexin 43 mRNA expression after BMP4 treatment is significantly downregulated when we treat the cells with this beta-catenin transcription inhibitor. These results were again recapitulated in VTC001 glioma stem cells. So that brings us to a model that looks a little bit like this. When BMP binds to its receptor, it's promoting the translocation of beta-catenin to the nucleus that then transcribes GJA1, or the gene that encodes for connexin 43. And then we get an increase in connexin 43 protein. And this result can be inhibited by the addition of LF3. So to summarize our AIM-1 findings, we see that BMP activates SMAD1 and 5 in glioma stem cells. BMP increases the connexin 43 protein and mRNA in glioma stem cells. And BMP4 treatment increases the nuclear localization of beta-catenin in glioma stem cells. And beta-catenin is required for the transcriptional increase of connexin 43 after BMP4 treatment. So when we refocus to AIM-2, we see that we're looking at the role of connexin 43 on Wnt beta-catenin during glioma stem cell differentiation. So interestingly, connexin 43 and beta-catenin have been shown to directly interact at tyrosines 265 and 313 on the carboxy terminal domain of connexin 43. This interaction can be disrupted by circ-dependent phosphorylation of these two tyrosines. However, this has only been shown in cardiomyocytes, and this has never been documented in glioma stem cells. So I did a co-immunoprecipitation to see if these proteins were interacting in our cells, and in fact they are. You can see that I did an immunoprecipitation for beta-catenin, and when we stained for connexin 43, there is an interaction between connexin 43 and beta-catenin. And this result was again recapitulated in VTC001 cells. And this is the first time in glioma stem cells that these two proteins have been shown to directly interact. So now that I show that they directly interact, where are they interacting? So we used immunofluorescence to determine where this association was happening. And you can see in my BMP4 treated cells that connexin is shown here in red and beta-catenin in green. And you can see these yellow puncta here along the plasma membrane that represent that these two proteins, connexin 43 and beta-catenin, are interacting at the plasma membrane, excuse me. And you can see that this result is quantified here. So I understand that this interaction is happening now, and I understand where it's happening. So what happens if I disrupt it? So we designed connexin 43 mutant plasmids. We mutated tyrosines 265 and 313 into glutamic acid and aspartic acid mutants. The glutamic acid and aspartic acid mutants are phosphomimetic, so they functionally prevent the interaction between connexin 43 and beta-catenin. And we also created a phenylalanine mutant that is unable to be phosphorylated and thus will promote the interaction between connexin 43 and beta-catenin. These mutagenesis experiments were done by Stacy Deaver and Taylor Wynn, who are other members of the Lemley lab. So, of course, we would want to use our connexin 43 mutants in glioma stem cell connexin 43 knockout cells. However, those tools are not yet readily available to us, so because we're currently generating them using CRISPR-Cas9. So we have connexin 43 knockout mouse mammary gland epithelial cells readily available to us, and these cells were donated by Dr. Mike Zietz of the Smith lab. So using this readily available tool, I transfected my mutant plasmids, and you can see here that there's not a significant overexpression of connexin 43 compared to the wild type. And when we did a co-immunoprecipitation, you can see that this interaction between connexin 43 and beta-catenin was successfully disrupted using our phosphomimetic mutants. And this interaction is again preserved in the phenylalanine mutant. So this is again really exciting. And when we summarize our AIM2 results, can't forget that. Connexin 43 and beta-catenin directly interact in glioma stem cells. BMP4 treatment increases the interaction between connexin 43 and beta-catenin at the plasma membrane. And we successfully generated our connexin 43 mutants, and I successfully transfected these mutants into our connexin 43 knockout cells. And we successfully showed that this interaction can be disrupted. So when we zoom out and we look at this data in the context of glioblastoma and glioblastoma treatment, we come to a model that looks like this. BMP4 binds to its receptor, promotes the translocation of beta-catenin to the nucleus, where it transcribes GJA1. That leads to an increase in connexin 43 protein, and then there is an increase of connexin 43 and beta-catenin at the plasma membrane. Now, we're not entirely sure what role this interaction is playing, and parsing out this interaction will actually lead us into our future directions. For example, this interaction could be sequestering beta-catenin at the plasma membrane, which will functionally prevent it from transcribing genes that lead to glioma stem cell maintenance. Or this interaction could be important for cell-cell communication, migration, or invasion. So the remaining questions that we have focus on these things. So how does the tumor microenvironment actually expose glioma stem cells to BMP? And is the connexin 43 beta-catenin interaction important for cell-cell communication, migration, invasion, and is it really leading to differentiation versus maintenance and versus quiescence, and how is that playing into this? And can the connexin 43 beta-catenin interaction be disrupted, and can it be a potential therapeutic target for glioblastoma? So thank you to everyone listed on this slide for your contributions to my work, and at this time I'll take any questions.
All right, questions for Natalia.
So first of all, Natalia, if I had the authority, I would award you a PhD right now for that work. Very impressive. So my question is, I think you demonstrated the importance of the beta-catenin and connexin 43, the necessity. I'm thinking in terms of your last statement about thinking about therapeutics, about the sufficiency part of the question and what other potential interactions there might be, and whether you explored that or thought about that.
So interactions between connexin 43 and
With
other proteins?
Yes. Yes.
We have not yet explored that, but there are, of course, other interactions with connexin 43. It's a hot topic. What sticks to the C-terminal domain of connexin 43? We've shown that it interacts with microtubules. We've now shown that it interacts with beta-catenin. And I do believe that there are several other proteins that are involved in cell-cell communication and migration that are important in regulating how GBMs are talking to each other and sharing kind of nutrients and things like that. So we have not yet looked into that, but I'm sure that there are several other things that we could talk about. Mm-hmm.
Any other questions?
That's a great question, Mark. I didn't sleep much. Just kidding.
All right, let's thank Natalia again. Great job. All right, our last talk from class of 2022, letter of distinction winners, is going to be from Ariel Badger. Ariel worked with Dr. Apel at Carilion Clinic and also reached out to Virginia Tech Transportation Institute to do some pretty innovative and very practically motivated research. So let's hear about driving.
Yes. So thanks for sticking with us till the end, but it is the end, last presentation. In this presentation, I'll be talking about two projects I've been working on. Not loud enough. Here, no. You know what? I can just use mine. Hello. Great. All right, so I'm going to be talking about two projects I've been working on with Dr. Apel in this presentation titled On the Road Again, Driving Safely After Upper Extremity Surgical Procedures. So diving right in, let's talk about driving. So driving is a near ubiquitous need in our society, as evidenced by the 229 million licensed drivers, because it confers a level of independence necessary for social engagement and participation. Now let's talk about surgery, specifically orthopedic surgery. So there are about 7 million musculoskeletal procedures performed a year. And if we focus on two upper extremity procedures, because they'll be relevant later, almost 600,000 are carpal tunnel releases and over 300,000 are rotator cuff repair. So because of the musculoskeletal involvement intrinsic to driving, a lot of orthopedic patients want to know, when can I drive after surgery? And that's where we immediately hit our gap in knowledge. As of 2016, there were only 40-some articles looking at driving fitness after orthopedic surgery, and 86% of those were limited to lower extremity and spine. Of the few that did look at upper extremity, 60% only studied the effects of immobilization with a cast and a splint rather than looking at post-surgical recovery. And the methods used primarily were surveys. These were provided to patients about 3 weeks to 144 months after surgery. So some real concern for recall bias. Furthermore, these simply just ask patients to say when they return to driving, as opposed to asking about narcotic use or driving fitness at all. A few studies looked at standardized tracks, but they all virtually used healthy volunteers, had a small sample size, or relied on subjective measures, just asking subjects if they felt impaired. Finally, driving simulators are being used more and more now, and they're a great tool, but they really preclude a real sense of danger. And that's evidenced by the multiple collisions seen not just in the impaired or surgical state, but even in the control state. And because I can quite confidently say none of us are getting into 2 to 3 accidents every time we get into our car, it's a little hard to apply simulator data to real world driving situations. So I'm sure it comes as no surprise that these all have contradicting conclusions, so much so that the most recent driver fitness medical guidelines by the National Highway Traffic Safety Administration have no return to driving recommendations following upper extremity surgical procedures. All the current recommendations are just overly conservative. So when we approached this question, we had just a few goals in mind. We wanted to stay away from a retrospective study that relied primarily on surveys or subjective measures in an artificial driving environment. We wanted more of a prospective study where we collected objective measures that could be correlated to driving fitness and do so in a naturalistic driving environment if possible. And that's where we were incredibly fortunate to work with the Virginia Tech Transportation Institute, and with their expertise and help, we were able to design this novel study to assess driving fitness after surgical procedures. But because this had never been used before in a patient population, we wanted to start with a proof of concept to show that the method was reliable and safe in measuring driving fitness. So we took our question and we made it specific to when can patients drive after wide awake, local anesthesia, no tourniquet, or Wallant surgery. So Wallant is a technique that's being increasingly used in minor upper extremity procedures such as carpal tunnel release. As the name implies, patients are wide awake during the procedure. They just receive a local anesthetic. And then right after the procedure is over, they just have a numbed hand and a bandage. So they want to know if they can just drive straight home afterwards. And because there are no driving guidelines, the decision's really left to the patient and the insurance company. So that's the title of my first and my official medical school research project. Modeled Volant does not impair driving fitness, an experimental on-road non-inferiority study. I apologize, all my titles will be spoilers. The hypothesis was driving in a modeled Volant state is non-inferior to driving in a baseline state, with the objective of determining driving fitness following a modeled Volant state. So we recruited 12 healthy subjects from BTTI's volunteer database. All of them were right-hand dominant. Then they went on what we called a baseline drive. So they got into this instrumented research vehicle up at VTTI. They had a safety monitor in the back who could intervene if necessary. And they performed 3 parking tasks in the parking lot and then went on a 45-minute drive around Christiansburg. Then they were led onto the VTTI Smart Road, which is a closed course, by a research vehicle. And this research vehicle will play a role in just a moment. When they returned to VTTI, all of their right hands were numbed in a pattern similar to what they would receive if they were undergoing carpal tunnel release. And then it was bandaged and they were sent on a post-operative or post-procedure drive right afterwards, which was identical to the baseline drive. Except this time when they were led onto a closed course, there was a box actually stashed under that leading vehicle, and we dropped the box to assess their response to a surprise event. So here I have a video of that surprise event. If you just look at the road, the box will drop. There it is. And Dr. Noah Orfield happily avoids it. So from our instrumented research vehicle, we got all of our primary outcome measures, which were kinematic metrics such as speed, longitudinal acceleration, lateral acceleration, yaw, and steering wheel angle. We also measured secondary outcome measures such as adverse events, hand use, outcomes to the parking task and surprise event, and we provided all the subjects with an evaluation after the modeled Volant just to see how they felt about the impairment. Then we performed a non-inferiority analysis. So for all the kinematic metrics, we determined estimated differences between baseline and modeled Volant drives using a statistical model. And just as a gross oversimplification, an estimated difference of 0 is more or less equivalent to no difference between the baseline and modeled Volant metric. Then we compared those estimated differences against practically significant margins, or what we called non-inferiority limits, which were specific to each kinematic metric. So to give you an example, for any acceleration data, the non-inferiority limit was an estimated difference greater than or equal to 0.05 Gs. And just to give you some perspective, that is a difference equal to taking a turn at 10 miles per hour versus 10.6 miles per hour. So our margins were really narrow. And so even if the estimated difference between the Volant and baseline metric differs significantly from 0, if it's 95% confidence interval does not include the margin, then there is no practically negative impact on driving fitness. So this is the key figure of this study. On our y-axis, we have the 11 kinematic metrics. On the x-axis, we have the estimated difference between the Volant and baseline drive. On the figure itself, we see the means of the estimated difference and the 95% confidence interval. Now, you'll probably notice that any estimated difference less than 0, or where the Volant metric was less than the baseline metric, we actually called it more conservative. And that's because it corresponded to slower speeds, less acceleration, smoother turns, and smoother steering. And so any estimated difference greater than 0, we called more reckless. But again, the most important thing is to notice the non-inferiority limit in the red. And you can see that none of the metrics get anywhere near that. So we were able to say the Volant state was non-inferior to the baseline state. So in conclusion, we recommend surgeons do not discourage patients from driving immediately after Volant hand surgery. And we could say this because of the non-inferiority analysis, but also because all the secondary outcome metrics had 100% pass rates across the board. And we published this in JBJS in September 2020. So back to our approach, we successfully were able to show that this method was reliable and safe in measuring driving fitness. And so now we wanted to bring it into a patient population. So we took our question and made it, when can patients drive after rotator cuff repair? And right now, after rotator cuff repair, patients are placed in a sling for 4 to 6 weeks, and they're discouraged from driving for about 6 to 12 weeks. So the title of my second project, again, spoiler, on the road again, rotator cuff repair patients can safely return to driving 2 weeks post-operatively. Our hypothesis was post-operative driving after rotator cuff repair at multiple time points is non-inferior to driving in a baseline state. And our objective was to evaluate driving fitness and adaptive behavior in patients prior to and after undergoing rotator cuff repair at multiple time points. So this is going to look very familiar, so I'm just going to highlight the differences. We recruited 27 patients undergoing rotator cuff repair at Carillion. They went on a baseline drive 2 to 6 weeks prior to their surgery, and this occurred in Roanoke, so we added in some urban and highway roads, and we got rid of that closed course surprise event. Then they underwent rotator cuff repair. We allowed for certain concomitant procedures and ultimately had close to the same number of right-sided and left-sided rotator cuff repairs. Then we had 4 post-operative drives, all of them identical to the baseline drive at post-operative weeks 2, 4, 6, and 12. So here's our non-inferiority analysis again. The figures probably look a little different because they're split into 2, and you'll also notice the non-inferiority margins on the left side now instead of the right. That's simply because we changed the reference point to the baseline. So now any estimated difference less than 0 is considered more reckless. Any estimated difference greater than 0 is considered more conservative. You'll also notice our kinematic metrics are labeled down the middle, and underneath each one we have 4 points. And those 4 points correspond to the 4 post-operative time points that we were comparing to baseline. So in this way, we can actually see how those change or if those change over the course of time. So the first thing to note is none of these estimated differences get anywhere near that non-inferiority margin. So all post-operative time points were non-inferior to the baseline drive. Where things get interesting though, is when we start looking at where we do get some estimated differences that differ significantly from 0. And we'll start with minimum longitudinal acceleration. So what that tells us is as early as post-op week 4, patients were actually braking less aggressively than baseline, and that continued to post-op week 12. And then if we look at maximum longitudinal acceleration and maximum absolute lateral acceleration, at post-op week 12, and specifically there, patients are actually accelerating more aggressively and taking turns more sharply. So on one hand, we could say they're getting more reckless. But rather than say that, we actually thought this finding shed light on the adaptive behaviors that are present in the baseline state, because a lot of patients undergoing rotator cuff repair actually have a chronic injury. So the baseline drive really isn't a healthy drive. It's not a healthy state. It's more a compensated state in response to the injury. And our hand use analysis further showed this. So what we did here was we separated out left-sided rotator cuff repair from right-sided. We looked at left hand use and right hand use independently. And then we looked at lower steering wheel hand placement and upper steering wheel hand placement, focusing on the upper steering wheel simply because individuals with rotator cuff injuries or rotator cuff repair cannot/should not raise their arms too high. And for the sake of time, I'm just going to focus on right hand steering wheel hand placement before and after right-sided rotator cuff repair. So again, this is the hand use ipsilateral to the arm that was operated on. And here, as a percentage of time, we have hand placement on the upper steering wheel and the lower steering wheel at baseline, post-op week 2, and post-op week 12. So if we just focus on the upper steering wheel, you'll notice that there's no significant difference between baseline and post-op week 2. So to say it a little differently, there's no difference in hand use before surgery and right after surgery at post-op week 2. But when we look at post-op week 12, we see a significant increase in upper steering wheel hand placement compared to both of those time points. Again, probably because of the improvement to shoulder mobility, and that actually contributes to safer driving. And we felt that showed the compensatory behavior that was probably present prior to surgery. So in conclusion, we recommend updated guidelines stating in the absence of other factors known to impair driving, patients who can drive prior to surgery may resume driving 2 weeks following rotator cuff repair. We said that because of our non-inferiority analysis, and also because we saw safe adaptive behaviors starting at post-op week 2. I couldn't go into that in this presentation, but just to give you a few examples, there was increased turn signal use, increased two-handed steering, and increased over-the-shoulder looking prior to merging. Also, we found that compensatory driving behaviors prior to surgery and heightened caution following surgery play important roles in patient driving fitness in real-world situations, and these adaptive factors should really be considered when designing future experiments. So we just submitted revisions to JBGS a couple of weeks ago. So a lot of people to thank, but if I can just give a shout out to three: Dr. Apel, obviously my mentor, really pushed this forward, especially during COVID. Dr. Teggy for all of our Zoom R coding sessions, and Dr. Perez for answering all the questions that I had about how to analyze these things. And thank you. I can take any questions.
All right. I know there's questions about this. Yeah.
Hey, first of all, great presentation, Ariel. I was just wondering if in your post-op data, when you look at the 2 compared to the 12-week, if any of the more reckless behavior could be explained by the patients just being more familiar with the course.
Right. So that was something we definitely considered as well. And that was one of the main limitations of our study, were learning effects. But what was interesting was in some of the other data, they're actually showing more conservative driving behavior, which is the opposite of what you would expect with learning effects. So I think because of that, combined with what we were seeing in the, more reckless behavior, it seemed like it was more a comment on adaptive behaviors prior to surgery.
Questions?
So, sorry, I got distracted signing things. I don't have a question, but I just want to say that every time I thought of something that was going to be the question, you showed me you had done the control and figured it out with respect to the handedness, the upper and lower wheel. So I was just incredibly impressed. That's fascinating. Very well controlled. Well done.
Thank you.
I got a question. Sorry, you're not done yet.
Oh, no worries.
So what are next steps in terms of making this actually become practice guidelines? What are the next steps for your group? But then more generally speaking, what would you hope to see happen?
Well, I do know for one thing, for our Willant study, that is already practiced over at ION. And so patients are already driving right after Willant procedures. And I feel like just with this current study, it just kind of pending its acceptance, I think it's kind of the direction we're going to go. And future studies for this lab are really focusing on lower extremity studies. So I think they're kind of happy with what we've done here. And now we're going to move more toward lower extremity studies.
Great. Immediate changes. So that's great. All right, let's thank Ariel. All right, so just a few more things here before I let you go on with your Friday. I do want to take a minute to recognize the students who have also been recognized for letters of distinction in research productivity. So you may have noticed which color. I think the red ribbons are the ones that denoted that. And so I just want to, you don't have to come down or do anything like that, but I do want to acknowledge those who received those letters. So Yazan Al-Shakani worked with Pete Apel again in Department of Orthopedic Surgery. So let's give a round of applause for Yazan. And Ariel Badger, of course, with her 2 publications straight out of a research domain study. So congratulations to Ariel also. And when we're making these selections, we're looking at scholarly productivity predominantly associated with your primary research domain study. And that can also include things like getting grant applications accepted or being selected as an oral presentation winner. So it's sort of a whole body of productivity work. So for example, Mallory Blackwell was also a recipient. She earned a grant from American Association of Neurology. And maybe I got the AAN right. So congratulations, Mallory. Chris Childers, we didn't hear from today, but he was also one of our letter of distinction in research scholarship and productivity. So congratulations, Chris. Jacob Hartman Kensler worked with Sarah Parker and Sean Safford to earn a letter of distinction in productivity. Mira Nikita worked with Dr. Charlotte Baker in the Department of Population Health Sciences. So congratulations, Mira. And then our last letter went to Parth Vaidya, working with Dr. Vishak John at Vistar Eye Center. So congratulations, Parth. Okay, we're gonna give out the student selected awards in just a minute, but I want to get the thank yous in before we kind of go to all the student selected awards. So Dr. Tegi is disappointed she was not able to join us, but I do want to verbally acknowledge all the work she puts in with so many of you, helping you do your R coding, think through your analyses, designing your hypotheses. So thanks to Dr. Tegi. Maybe she's logged on, maybe not, but give her a round of applause since she's not here. I also want to thank and sort of foreshadow Dr. Nikki Worthington's work with us in research domain. She is our clinical research education director. Is that, I think I got your title right. And so she's been at the poster session. She's going to be helping evaluate, but she's really helping us look at our whole curriculum, and we're excited to have her on board. So thank you, Dr. Worthington. Along the lines of somebody who's helped so many of you, Kara Spivey, is she still here? I don't know whether she's in the other building. Okay, so Kara Spivey, clinical research coordinator for VTCSOM, really instrumental in moving so many of our studies forward and making sure they're staying in line with regulations and also helping you practically implement some of these studies. So thank you, Kara. We had a lot of people help with facilities, get everything organized between Riverside 4, Riverside 2. So Sarah Glenn, Brian Stanford, Clay Davis have helped and are going to help tonight as we break everything down. So thank you, everybody. And that's my chance, that's my trigger to remind you, you all have M4s, you all have posters up, right? So go take your posters, don't immediately throw them in the trash, please. I encourage you to talk with your mentor. Is there a place that you can put that poster up to display the work that you've done? We always like a few of the posters here to display, but check with your mentor and see what they want to do with that poster, unless you want it up in your apartment or whatever. That's okay too. So continuing along the lines of thanks. So we have a fabulous communications team here at VTC, and I hope many of you have looked at some of the stories that have come out and some of the videos that they have made. Catherine Doss has been instrumental in helping that happen. Ryan Anderson has been here. He's going to be putting out some fabulous pictures, I know, from today's symposium. Vian Greek has helped with our website. Josh Myers oversees all that team. So thank you for helping us with the symposium and make it happen. I really appreciate that. And as usual, we can't do this without IT. We've been streaming this via YouTube, and I've been doing my best to stay on top of everything. But obviously, we've had incredible help from Dustin Womack. Dale Worrell is up at the top here. Thank you so much, Dale. Really appreciate it. And then worked with Brad Anglin over at FBRI as well. So thanks to all of the IT people for helping us get this done also. And then Dr. Mutchison has been behind the scenes helping us tabulate all of your QR code entered voting for posters. And so we appreciate his help with that. I don't even know the results yet, but we're about to find out. So thank you, Dr. Mutchison. And then the people who are instrumental, who you guys interact with all the time and who I cannot survive without: Jessica Flowers, Crystal Barnett. Thank you, both of you, so much for doing all of this. They're the best. I'm very fortunate to have such a fabulous team. All right, so now we've got some certificates here. The students voted on all of these fun awards that hopefully you had a chance to go through. All right, so I know many of you are up for this award, but this one is the Most Hurdles Overcome Award. I know probably everybody thinks they deserve it, and you all do, but everybody voted for Mallory Blackwood. So. Sorry, they are so hot off the presses that we haven't signed them yet. So, right, it's official. Otherwise, it would not have been official. You were right. Congratulations. Thank you. Oh. You definitely overcame the hurdles. You're here. Oh. All right. So, most exciting discovery. Again, there's a lot of you that I would have voted for, but the winner of this one is Chris Childers. So congratulations, Chris. Three for three, huh? Congratulations. Okay, and we heard from some presenters today who I think this would have been a good one for, most likely to change clinical practice this year. So, this would have been a hard one for me to choose, but Juan Choi, Juan. All right. Most promising preliminary data for an NIH grant. Natalia Sutherland. Does that go along with your honorary PhD that Dr. Friedlander just gave you? All right. Most tweetable results. Ariel Badger. All right, in recognition of best visual design for your poster, Dinesh Lal. That's right. Congratulations. All right, our last one for sort of overall best poster presenter, Corey Cablet. All right. Thanks so much, everybody, for attending. We had some absolutely fabulous presenters and excellent poster presentations in class of 2022. You did an amazing job with research. You had a ton of hurdles to overcome, but everybody walks out of here very proud. Great work, everyone. Thanks so much.